Hi everyone, welcome to our session on controlling life. So we're going to be running through lots of different neuro topics today. We're going to start with Ash, who's going to go through stroke and spinal cord stuff.
Yes.
Forgot from there. And then we're going to go to Ganesh, who's going to go through eyes and ears. And then Ellie is going to cover Parkinson's, and then I'm going to finish by going through dementia and depression. And any questions you have, just either pop them in the chat or feel free to just unmute and ask if that's easier. But we will try and keep an eye on the chat as well. And we've also got a poll going. So for all the SBAs, you can answer on this poll. So if you scan the QR code, it should take you to it and you can just vote as we go through. So we'll leave that up for a second just while you guys.
So hi guys, I'm Ash. I'm an F1 doctor in London. So I'll be going through spinal cord injuries first, and then I'll go through stroke after this. I put my email in there as well because I won't be around later. So just pop me an email if you have any questions or want me to explain something a bit more. It's going to be a very quick whistle-stop tour of everything. So if I'm going too fast, just let me know. Cool. So we'll carry on.
Okay, so we will start with the spinal cord anatomy here. So within the spinal cord, it's divided into various bits. So you've got your white matter and your grey matter. And then you've got your dorsal horn here and your ventral horns, which are here. So just remember, the ventral side is the one with the much larger horns, and the thinner horns are on the dorsal side. Then you've got different groups of tracts. You've got your motor and your sensory. So you've got your motor tracts, which are your descending tracts, are going from the brain down to your peripheries. So you've got the cortical spinal tracts, and you've got the lateral and the ventral parts of this, which controls your voluntary movement. And I'll go into a bit more detail about this later on. And then you've got your ascending tracts, which are going from the peripheries to the brain, which carry all your sensory input. So you've got your dorsal columns, which is your deep touch, proprioception, and vibration. You've got your spinothalamic, which is your pain, temperature, and light touch, which is also divided into your lateral and your ventral. And I put this diagram in here just so it highlights it a lot better. So going on to start the sensory pathways. So we'll start off with the spinothalamic tract. So your lateral spinothalamic tract is your pain and temperature sensation, and your anterior spinothalamic tract is your crude touch and pressure. So you can see that the sensation here is picked up by your nociceptors or your thermoceptors. This then travels in through the dorsal root ganglion, synapses in your dorsal horn here. So this is your first order neuron. Then this here is your second order neuron after its synapses. So this crosses over within the level of the spine, and it usually ascends about 1 or 2 levels before it synapses in the dorsal horn and then crosses over. So it crosses over and then it goes and it synapses in the thalamus here. And then it travels to the cortex via the third order neuron through the BPL nucleus in the thalamus to the primary somatosensory cortex. So the key thing here to remember is with the spinothalamic tract, there's 3 order neurons. It synapses twice. It crosses over 1 or 2 levels above the level at which it originates. And the key places it crosses over are in the dorsal horn and then in the thalamus. Okay. next we've got the dorsal column. So this is also known as the dorsal column medial limbic pathway, because these are the two places where it travels through. So you've got your sensory input coming through here. So it's from your mechanoreceptors or your proprioceptors. And this is how it kind of detects your fine touch and pressure, proprioception, and your vibration sensation. So it goes through the dorsal root ganglion. It has one synapse within the dorsal horn. Then one branch from it goes all the way up to the medulla. And then in the medulla, it synapses. And then it crosses over in the medial lemniscus. And then goes all the way up to the thalamus. And it synapses again in the thalamus. Again, going by the VPR nucleus, goes to the primary somatosensory cortex. So, key thing here to remember is there's two branches within the spine, at the level of the spine. It crosses over at the level of the medulla, where it also synapses for the first time. And then it goes to the thalamus, to the cortex. The next one, and just to add here, so within the dorsal column, there's two pathways. So you got the fasciculus cutaneus, which is your lateral, and that's all the nerves going from T6 and above. And then T6, anything below T6 is your fasciculus gracilis, which is more medial. So I'm not sure if you can see here, but these are the two bits of the dorsal column. If I go back, easy to see. So you got your fasciculus gracilis and your fasciculus cutaneus here. And the way to remember it is your legs are more centered, so your lower limbs, lower part of your trunk, and then your upper limbs and the upper part of your trunk are just on the outside, because your arms are more lateral than your legs. Then finally, you've got your spinal cerebellar tracts here. So this is for posture and coordination. So it's important to get input from both sides. And then it goes up on one side of the spinal cord, and you'll have two tracks going up on both sides. And this is what allows you to balance out and just kind of keep your balance and know where different parts of your body are in relation to the rest. So there's only two neurons here, and it synapses within the spinal cord, and it goes up through the medulla, through up, and then into the cerebellum here. Okay. So next bit, going through your motor pathways. So you got your corticospinal tract, which controls your involuntary movement. So the lateral tracts control all your distal muscles, whereas the anterior tracts control your proximal muscles, so the ones which are closer to your trunk. So your lateral tract decussates at the level of the medulla, and this is about 90% of them. And then anterior tracts, about 10%. It decussates at the level of the spinal cord and the anterior commissure. So this is why you'll have some reserved motor function if you have some lesions higher up in your lower limbs. And then you've got your corticobulbar tracts, which is mostly all the skeletal muscles in your head and neck. And this is where all your cranial nerves kind of come in. So you've got your cranial nerve 5 for muscles of mastication, so all your chewing reflexes, your facial muscles, which is your cranial nerve 7, cranial nerve 11, so your SEM and trapezius, so all that shrugging motion, and then cranial nerve 12, which is movement of your tongue. Then you can see here all the input comes in from these muscles, goes in through these tracts and crosses over in the medullary pyramids and goes all the way up to your cortex. An SPA here. So you've got a 32-year-old man who comes into A&E with a stab wound in the back. Your consultant decides to quiz you on the spinal pathways. What signs would the patient be expected to show if the spinal cord was stabbed on the anteriorly on the left side of the lumbar spine? So I'm just going to open the poll now and give about 30 seconds. Give it about 10 more seconds. Okay, so I'm going to close the poll. I'll give it 10 more seconds so more people can answer. Okay, I'm going to stop the poll there. So most people have put down D, which is the correct answer. So this is an anterior lesion, which is on the left side of the lumbar spine. So this means the motor impairment is going to be on the same side because that crosses over much higher up. And then you have a loss of touch and vibration sensation and the proprioception on the same side as well. Then you have an impairment of pain and temperature sensation, which occurs on the opposite side of the lesion as that crosses over at the level of the spinal cord, and it's usually 2 levels below. So the deficit itself, so if you have the lesion at, let's say, L1, and then the pain and temperature sensation, the deficit itself will be just below L2, L3. Just because it crosses over down there and then goes up. So this is also known as Brown-Séquard syndrome. So where you get this deficit on both sides, but only partial deficits on either side. The other ones to remember is the anterior cord syndrome. So this is where you have a complete loss of the motor, pain and temperature below the injury, but you still retain the proprioception and vibration sensation because that's on the posterior side. Then the other one to remember is your central cord syndrome, where this is usually due to the forced hyperextension. So you have both a sensory and a motor deficit in both the upper, and it usually affects the upper more than the lower extremities. Okay, so this is just going over the spinal cord nerve anatomy really quickly. So anything around the level of C4 to 6 will affect your limbs, so upper and lower limbs. So that's your tetraplegic or quadriplegic.
Below the level of T1, it's your paraplegic, where it's just your trunk and your lower limbs. And then anywhere like around L1 and below, so your lumbosacral, will be just your lower limbs which are affected. And then the other bit to remember is your cauda equina, which mainly affects your bladder, bowels, and your lower limb. Just in line with any spinal cord injuries, just wanted to go through concussion as well. So main symptoms of concussions, like headaches or feeling this kind of increased pressure in your head because of raised intracranial pressure. You might have a temporary loss of consciousness, a bit of confusion or feeling a bit foggy. You might just have a slight amnesia as well, just kind of forgetting what happened during the events. Any sort of dizziness or seeing kind of floaters, kind of like stars or things like that. Any ringing in the ears, nausea, vomiting are usually quite common. Any kind of slurred speech, any signs of stroke as well sometimes. And just delayed response in general and feeling a bit dazed. In terms of the mechanism, so if you imagine you've kind of hit your head, what happens is the brain's just sitting there in some fluid and it rocks forward and then goes back. So you get this injury on both sides of your brain, so the front and back, or if it's going side to side, one side and the other as well. And it's this shearing of the neurons and the blood vessels which causes this injury, and you can get this sort of diffuse axonal injury because the neurons have been kind of sheared apart, and the level of impact will determine the amount of damage that is caused to the neurons. And most of the symptoms that you get, such things like more like stroke-like symptoms, are usually caused by the actual interruption to the neural communication. So in order to score how bad a concussion is, or just any kind of head injury, Glasgow Coma scale is used, and it's not just for any kind of neurological issue, it's just in general you just calculate a GCS for a patient just to kind of identify how responsive they are and how unwell they are. But the number doesn't always reflect the clinical picture, so it's always good to just see the patient. So the way I remember it is start with motor, there's 6 points, then verbal is 5, and then I is 4. So maximum 6 points if they're able to just obey your commands and do what you ask them to do. 5 is if they're localizing to pain. So if, for example, you're squeezing the trapezius, if they're able to move your hand away, that's 5. But if they're not listening to you and obeying your commands, then they're not actually properly awake. And then if they're scoring a bit lower, so if they're able to try and shuffle their body away from pain, but they're not actually able to move you away, that's 4. If you can see some flexion, so they won't be able to actually reach out and move your arm or move themselves, but they're responding to pain by just flexing their limbs. If they're extending, so kind of arching to the pain, that's 2. And no response always scores 1. Then looking at your verbal response, if they're able to talk to you, they're completely orientated, they score maximum 5 points. If they're a bit confused, but they're actually verbalizing, then that's 4. If they're not making any sense, they're just making kind of inappropriate words, or just they're not like forming full sentences, that's 3. Just plain sounds is 2 points, and then no response is 1. And then for eye opening, if they're spontaneously opening their eyes. So if the patient's asleep and you wake them up and you can tell they're able to actually just keep their eyes open themselves, you still give them 4 points. If you have to really like wake them up, then like shake them, kind of get them to respond to pain, and then they open their eyes. That's 2, 3, kind of decide by the bedside. And then not responding at all, not opening their eyes at all is 1 point. So the minimum score you can get with your Glasgow Coma scale is 3. It will never be 0. And anything below 8 is something that's a bit worrying, usually. Cool. So we've got another SPA here. It's got a patient that has absent reflexes, flaccid paralysis in just the left lower limb. They also have some sensory impairment in both lower limbs. Where is the lesion likely to be? So I'll start the poll. Just going to give it about 10 more seconds. Okay, I'm going to close the poll now. So I can see most people have answered C, which is correct. Well done. So with lower motor neuron lesion, there's a loss of the muscle tone and reflexes, which is what causes this flaccid paralysis. So this could be the case with like peripheral lesions, E, so your left lower motor lesion, which occurs peripherally, but because there's also the sensory impairments included here, it's likely to be at the level of the spinal cord, which is why it's a left lower motor lesion at the spinal cord. The sensory impairment, if we remember from before, is because half of them cross over at the level of the spinal cord, which is why both limbs are affected, and that's your clue here to tell you that it's at the level of the spinal cord. I'm changing. Okay, there you go. So just to go through your upper and lower motor neuron lesions. So in general, you'll have this kind of weak paralysis for both. The way to differentiate is looking at the actual muscle tone itself. So in lower motor neuron lesions, the muscle tone's usually absent or just really poor. So for example, your leg will just feel a bit like jelly, for example, and just very flaccid. The reflexes will be weak as well, or sometimes absent. And you'll see this muscle wasting because the muscles aren't really being stimulated at all. Whereas with upper motor neuron lesions, you'll have an increased muscle tone. Your reflexes will be a lot more exaggerated, and you'll also be Babinski sign positive too. And the muscle mass is usually maintained because you've got this constant stimulation, and it's your upper motor neurons which help kind of regulate this by kind of almost dampening down that stimulation to stop your muscles from being overstimulated and being very like contracted all the time, which is why you'll see anyone with kind of anyone with like any birth defects which have upper motor neuron lesions, they'll just have their limbs in this flex position where it's really, really stiff.
So I just want to also go through the reflex pathway. So remember, some of the pathways have two branches. So you have your input coming from your sensory receptors, going through that sensory neuron into your dorsal horn. At this point, you have a branch going up to the brain, and you've got a branch which synapses within the dorsal horn. You have this relay neuron in there, which relays this information into a motor neuron. So this motor neuron then comes back and then stimulates your muscle depending on your sensory input and also the feedback from the brain as well. So in this case, we've got a tendon hammer, and this is just checking your knee reflex. So you got your tendon hammer, you hit the patellar tendon to elicit the knee reflex. So this basically stretches that patellar tendon, pulling on the quads. So this stretch receptor stimulates an impulse going down the sensory neuron, goes all the way into the spinal cord, synapses, and then synapses to two different neurons. So the relay neuron here, got the branch going off into the brain, and then synapses here on one of the other motor neurons going back to the effector. So this stimulates your quadriceps to contract, which kicks your legs out. You also have the relay neuron, which relays this information all the way to your hamstrings here, which is your antagonistic muscle group, which is relaxed, and it basically stimulates that to contract, so it counters it, or it prevents the stimulation to your hamstring so you can kick your leg out. And in the case of the reflex, because this doesn't get the stimulation but your quadriceps do, that's why you end up kicking your leg out. Similar things happen here. So you've got a hot object here, your finger touching it. This message gets kind of relayed back to you, your bicep here, to contract and move your hand away from this hot object. So the first instant is moving away from whatever this bad stimuli is, and then your brain kind of receives the information as well and figures out what's causing it. And then this is this diagram here at the top of where the eye is. It indicates kind of how your movement's coordinated in order to do all this voluntary movement, whereas both these reflexes, which are for pain and the tendon reflex, are both involuntary. So with your voluntary movement, you've got your eye, which the stimulus, which is a glass of water. So that sensory input goes into the brain. It also kind of reflexes, there's an arc which goes straight to your motor neuron as well. That stimulates your arm muscles to go and grab and keep hold of this glass of water. And then you've got your brain also making that decision to coordinate these movements, and it can contract, and it decides on which muscle groups to contract and to what extent in order to not, one, crush the glass and break it, and also to keep hold of it so you don't drop it. So it just coordinates that amount of contraction in there and the level of pressure you put into that hold. The next thing I want to go through is the MRC muscle strength grading. So this is really useful when you're doing a neuro exam, just to kind of grade the amount of power a person has in their muscles. So 5 out of 5 is just your normal kind of movements that you would normally do. So being able to raise your arm and hold it against gravity and prevent someone from pushing it down. Grade 4 or 4 plus
depends on how much they're able to resist you from trying to move their limb. So if they're holding their arm out in the air and you're pushing it down, just the resistance of it. So sometimes there might be a slight weakness, but that might just be generalized weakness, especially in elderly patients who still have good muscle strength, but they wouldn't be able to resist you just because you might be stronger than them. So it's a bit unfair grading them a bit lower. So this is where you kind of give them 4+, maybe consider giving them a 5. But if you're pushing it down and it moves a bit and they're struggling to keep up, then give it a 4. And then if they're able to lift up their arm, but when you go put some resistance on it and their arm flops back down, that's 3. If they're unable to hold their arm up, but they can move their arm around, then that's a 2. And if they're not able to move their arm, but you can see some effort, then that's 1. And then no contraction, no movement at all, no signs of any effort would be 0. And this is actually, we're coming on to this a bit later. This is really useful, especially when you're assessing someone who might have had a stroke too, just to kind of compare both sides to see if there's any asymmetry in the amount of power. So just to quickly go through the pain pathway itself, and how opiates work and just pain management in general. So the spinothalamic tract is your main pain pathway. So the pain information is carried by your A delta fibers, and these are slow conducting and the slow conducting and unmyelinated C fibers also do this. So your A delta is your fast and your C fibers are your slow ones. And these travel up to the brain to just tell it there's like this unpleasant sensation. So pain is just subjective. So your brain's not detecting pain itself. It's just more of the unpleasant sensory input, and the pain itself is just an emotional experience from this unpleasant sensory input that you're getting. And the main reason for this detection is just to kind of indicate that there's potential tissue damage that can be occurring. And there's a lot of other things which can kind of impact the level of pain that you feel for certain things. So any kind of your personality, for example, just your any emotions at the time, any kind of cognitive or social components that kind of add to that too. Cool. Then just going through the pathway itself, so you can see that these sensations are picked up here, goes up the spine, it crosses over at the level of the spine, and it goes up through the periaqueductal grey, where it synapses in there to kind of modulate the pain, and then it also goes up into your cortex, somatosensory cortex as well, and that kind of regulates it. Because it sends out fibers down as well, just to modulate the pain, to kind of dampen it down if needed.
So I thought this was just another useful diagram to add in here for you guys to just look through for your revision. And just the last little thing that I want to add to what I said. So the main brain regions which control these pain experiences, your anterior cingulate and the insular cortex, and also your nuclei in the amygdala and the hypothalamus. So kind of pulling together all your memories and forming that kind of emotional experience for it. And this is what kind of sends out projections into the periaqueductal grey, which the pain pathway is already going through, which modulates the pain signaling. And this releases any endogenous opiates to modulate the pain and either dampen it down or facilitate it to make it worse.
SBA before I go on to how opiates work. So patients receiving morphine for severe pain. Which of the following describes the mechanism in which morphine acts? So just open the polls. Give you about 30 seconds. About 10 more seconds. Okay, cool. I'm going to close the poll now. So I can see everyone's put down E as the answer, which is correct. So there's the morphine itself acts on the mu receptors in the CNS, and that helps kind of just cut off the pain sensation so you don't feel it. The key things to remember are it also acts both centrally and peripherally, and this is where you get all the side effects of it. So kind of your decreased gut motility, might get some nausea with it as well, affects your appetite and things like that too. And
so just quickly going through the way morphine works. So this is basically how your endogenous opiates work. So morphine just mimics it and acts on the same receptors. So your mu receptors is the main one that it reacts on. So it aims to decrease the release of substance P and glutamate from all your first order neurons in the substantia gelatinosa of the spinal cord. So this is where your spinothalamic comes in, and it crosses over in synapses. So it's just inputting in there and just kind of dampens down that sensation. It also hyperpolarizes your second order neurons to prevent it from sending information up to the brain. So you don't perceive that pain as much anymore.
So there's various different receptors it does also act on. So the main one I mentioned is your mu receptors, and I've just put all the different effects here. So it also affects kind of your spirit, it causes respiratory depression, sedation is the other one as well, and sometimes a bit of euphoria and get a bit of addiction. So the other receptors are the kappa, delta, and you also got your kind of orphan receptors. Most of these are in the CNS, and this also adds to your kind of analgesic effect that you get. With the orphan receptors, this is more related to your tolerance to the mu agonist. So as you kind of build up tolerance to morphine, it also affects the appetite, which is kind of regulated by the orphan receptors here. And just going through the different types of pain, you've got your somatic, which is more localized pain. So this is more like your skin, for example, and muscles. And then visceral pain is more your kind of organ pain, that, like, for example, your heart, your lungs, things like that. Any kind of like heart attacks, for example, is you don't feel it in the heart. It's just more in the general area, which is why it's generalized pain. So that's more like your aches and like feeling more pressure. And then neuropathic pain is usually due to damage to the peripheral neurons. So you get this kind of burning sensation, and it sometimes radiates and feels like it's like these little electric shocks. And this is more in a dermatomal pattern. And these are just lists of examples. You'll get access to the slides later, so I'm not going to go through this right now because I'm a bit aware of time. Cool. I think that's it. The just the other little bit here is I've just put a little diagram of the parasympathetic and the sympathetic nervous system here, which I thought would be useful for your revision, but I wasn't actually planning on going through it. I just kind of put it in there as just reference for you guys because I thought these diagrams were quite good at explaining them. That is all the spinal cord stuff I wanted to go through. So the
last thing I want to go through is neural control of maturation. So most of this is all involuntary until you get to the point where your bladder is really full and you have to actively think about kind of holding it in. But there is an element of it which is involuntary and an element of which is voluntary in order to control this so we don't have any accidents. So as your bladder gets filled, your bladder stretches, and this sends off a signal to the spinal cord. And this is at the level of S2, S3 mainly. This then returns this kind of through your parasympathetic system. So it excites the detrusor muscles and it relaxes the urethral sphincter. And this is what causes you to just void your bladder. However, we need to also make sure we're in a suitable place to do this, which is why you've got signals going up to the brain, so to the pons specifically, and then signals coming back down from the pons to counter this. So you've got these motor neurons which go to the pudendal nerve, to your external urethral sphincter, and this basically contracts and keeps it all closed in so you don't end up having any accidents, and you retain your urine until you're ready to go void your bladder. And then when you voluntarily think to void your bladder, this then all relaxes and you can empty your bladder. The main reason I wanted to just kind of mention this is with any kind of spinal cord issues. If you have a lesion in the spinal cord, you end up losing this control of your bladder and become incontinent due to this, because you're not getting that input from the pons going down in order to kind of do that voluntary control. So once your bladder's full, it just empties out on its own. I'm not going to answer any questions right now. I can't see any questions in the chat either. So I'm going to carry on going to stroke. So just quickly going through just general cortical anatomy. So I'm not going to go through this in too much detail, but your cortex just kind of maps out different functions of the brain. So you've got your motor and sensory areas. So your motor's in kind of frontal lobe, sensories in your parietal lobe, and then your occipital for your vision, temporal has kind of your hearing, language and memory, and then your cerebellum is more to do with your posture and balance and coordination, and your brainstem is all your vital functions, so like your breathing and heart rate and consciousness is in there. Just quickly going through the blood supply to the brain as well. So you've got the major vessels, which are your anterior cerebral arteries. Then you've got your middle cerebral arteries here, which is one of the largest ones, and then your posterior cerebral arteries coming off there. They're all connected by the communicating arteries. So you've got your anterior and posterior communicating arteries. And then this circle of Willis is basically supplied by your internal carotid and the vertebral arteries to form this circle. And then you've got other branches coming off the basilar artery here, which supplies your kind of brainstem, your cerebellum as well. And these bits are quite important because
you'll get these focal neurologies with things like TIA and some smaller strokes, which you might need to identify which branches are affected when you have an ischemic or hemorrhagic stroke, for example. And just a quick whistle-stop tour of the cerebral sinuses. So venous drainage is there just kind of located between the two layers of the dura here, so you can see that. There's no valves in there, which allows the flow to be bidirectional, and if there's any kind of blockages in there, that can increase the backlog of the drainage and leads to like increased intracranial pressure. And one of the key pathologies to note here is your cerebral venous sinus thrombosis. Just to quickly go through the drainage itself. So you've got the cortical veins here, which drains into the superior sagittal sinus. So this big like pipeline here. This then goes meets up with this straight sinus, which is draining things from the inferior sagittal sinus, which is just below the superior, and that's draining things from the middle, and it meets at the confluence of the sinuses here. This then drains into the transverse sinus, which goes right and left, comes down to the sigmoid sinus, and then they all drain out into your internal jugular vein, and then just goes into your venous system systemically. So just another SPA here. So you got a 64-year-old male, Mr. Pingu, who's sitting and watching TV one evening when he notices he couldn't lift his left arm. When he stood up, it dropped to his side, and he described it as if it were dead. He became increasingly worried and called an ambulance and was taken to hospital. On examination, he had no other motor signs apart from the left arm weakness sensation, and sensation was intact. It resolved after an hour after being in A&E. Where is the occlusion likely to be? So I'll open up the poll. I'll give it about 10 more seconds. Okay, I'm going to close the poll now. So it looks like a split of answers. So the correct answer is A. So it's an anterior cerebral artery likely infarct, and in this, so just going through the vascular territories in the brain. So this is your anterior cerebral artery territory, and it also kind of goes through the middle here. Your middle cerebral artery kind of covers your temporal and just the more lateral side of your frontal and parietal lobes. And then your posterior covers most of your kind of occipital, the lower part of your temporal lobe, and just some of the parietal as well. So more like the back of the brain. And just kind of, if you map it onto the functional areas of the brain, you can kind of see the motor bit here is within part of the middle and the anterior cerebral artery territories. So the next bit I want to go through here. So this is your homunculus, and it represents like the amount of information gathered in each part of the brain for each part of your body, and the kind of proportions of each part of your body depends on how much input your brain has for that area. So if you look here, So looking at the anterior cerebral artery territory, it's covering the part of the homunculus which is kind of supplying your arm here. So if we look at this is your motor bit here, so your arm's kind of in that region. So you can kind of argue it's middle or anterior, but it's mostly anterior because it's just the arm that's affected. If you had any kind of facial signs, you might start considering maybe it was the middle. So quickly, same case, just which kind of cerebral vascular event occurred. So open up the polls. So just going to give you 10 more seconds. All right, I'm going to close the polls now. So everyone's put down C, which is the correct answer, so well done. So the fact that it resolved very quickly whilst he was in A&E kind of points towards more of a transient ischemic attack than a full-on ischemic stroke. And he's got clear risk factors for having a stroke as well, which I will quickly go through in a bit. So just to differentiate between a TIA and stroke. So the definition for a TIA is a transient episode of neurological dysfunction, which is caused by a focal brain or spinal cord or retinal ischemia without any acute infarction. So there's no actual cell death, but it's just a blockage of the blood supply to that bit of the brain. So it's kind of almost paused, but then once the blockage clears up, it kind of regains its function again. Whereas with a stroke, it's a cerebrovascular accident which causes that interruption to the vascular supply, which can cause that irreversible damage because the tissue's already started kind of dying. The most common type of stroke is your ischemic, and then you've also got another type which is your hemorrhagic stroke. And it's really important to differentiate between these two before you decide on which treatment course you'd go down. And I'll come on to that a bit later on. So just to quickly go through ischemic stroke. So because the neural tissue is very metabolically active, it dies really quickly once you cut off the oxygen supply. And that's what leads to these neurological deficits. Within the area itself, you've got the ischemic core, which is primarily affected, and then the penumbra here is the more viable brain tissue, which isn't getting oxygen, but it's still viable, so you can kind of reverse the damage to that area, whereas this ischemic core, you can't always reverse the damage. And this is why it's really important to act quickly to prevent this ischemic core from expanding into the penumbra and making that irreversible. Causes include like any emboli which is thrown off from any atherosclerotic arteries. So one of the main risk factors for this is AF, so atrial fibrillation. So your blood kind of goes around within the atria, so it gives it more room, more time for it to start clotting in there, forming an emboli, which can get thrown off when it gets pumped around. And other just general risk factors which might put a patient at risk of getting a stroke is things like diabetes, age, smoking, hyperlipidemia, and hypertension, because all of these kind of are risk factors kind of clogging up your arteries and forming clots in your arteries. The main treatment is just to kind of prevent that infarct from spreading, like I said. So again, just kind of going back to what I mentioned before, where you can it can be one artery or the other. So you've got these watershed areas between the different territories. So if there's any infarcts which are localized along these boundaries, they're known as watershed infarcts. They're more vulnerable to kind of having reduced perfusion, especially if they've got other things going on, so like hypertension, any kind of reduced flow due to like stenosis in the carotid arteries or any occlusions in there, and just having a lack of any collateral supply makes them more susceptible to getting kind of occlusions and infarcts from any small occlusions. So things like hypertension can, once you kind of get the blood flowing and the blood pressure up, it kind of helps reperfuse it. But if they've already got an infarct somewhere near the boundaries, then this whole area doesn't overlap. Therefore, you'll get these little infarcts here, and you can see on this scan here, you can see these areas where you've got a bit of an infarct there in these boundaries. I will go through these scans and how to kind of differentiate between ischemic and hemorrhagic in a little bit as well. Just to make you aware, you don't need to know too much of this right now, but there's two different criteria which they use to classify strokes. So the Brantford or Oxford stroke classification kind of tells you this, and the next one I'm going to go through tells you like the prognosis for the patient after a stroke. So with this, the key features you're kind of looking out for with the Oxford classification is looking for any kind of unilateral weakness with or without the sensory deficits in the arm, legs or face. Looking for any kind of visual defects or any kind of higher functions such as like visual spatial awareness or any dysphagia. And then you've got your Nihss score, which is where you do a full neurological examination, including like looking at their GCS, and then scoring on them on individual criteria. So anything that's below a 4 is usually a good outcome. Then 5 to 15 moderate, 16 to 20 moderate to severe, and then anything above 21 is very severe. And they kind of use this to decide if a patient can be a good candidate for thrombolysis and if they can regain their function following thrombolysis. They also put in other factors and look at other things such as age and any kind of comorbidities that they have to see if they would be a good candidate too. And it's not purely just based on the score, but it's good to have that number there just as an indication. So quickly go through hemorrhagic stroke. So they arise commonly from the smaller blood vessels which come off the middle cerebral artery, and these come up off at a sharp angle. So the way I think about it is, if you have a tree branch with little twigs coming off, the more closer they are to 90 degrees to the actual branch itself, the more likely it is to break off. So I think so the angle at which these branches come off the MCA will determine how likely it is to kind of rupture. And these kind of areas are usually around like the lentiform nucleus, around the pons and the cerebellum, which is why you get these hemorrhagic strokes in there. Other things kind of that put you at risk are any kind of atrial venous malformations, hypertension, if the patient's on any kind of anticoagulation therapies, and also age is another factor here. The main aim of treatments for this is to reduce that intracranial pressure, and it can either be conservative management, and a lot of it does tend to be conservative management, especially if they're elderly and have loads of comorbidities, or surgical management where they do surgery just kind of reduce that pressure. So the way to differentiate between an ischemic and hemorrhagic stroke is using a CT scan. So any hyperattenuation, so any kind of increased brightness like this one, indicates blood. So that indicates a hemorrhagic stroke, whereas hypoattenuating, where it looks a lot darker, indicates it's an ischemic stroke. So you can see this region where there's the ischemic region in the brain following the stroke. And then the other one to know is your subarachnoid hemorrhages, which so this is quite a good one where you can see the bleed here. So it's hyperattenuating the brightness just along here, which is your subarachnoid hemorrhage. And these are usually quite hard to pick up on CT. This just happens to be a really good one to look at. And just quickly going through the management. So that CT scan is important to do without contrast, just to see if it's a bleed or not. And if it's confirmed ischemic stroke, then this is where, if they're within the 4.5 hour window of their onset, then you can thrombolize them. Give them some aspirin just to help prevent them from clotting any further. Put them on oxygen if they've got low sats. Just do their bloods, do ECGs and everything, just to make sure there's nothing else going on. And then with hemorrhagic stroke, as I mentioned, neurosurgical consultation, just to identify if they need any if it's conservative management or if they're going to surgically intervene. Stop anything that might be worsening the bleed, so any anticoagulants or antiplatelets. And then with ischemic, thrombectomy, thrombolysis is another thing, especially in younger patients. Might be indicated as well, just to try and remove the clot manually and try and salvage the brain tissue. But there's a lot of risk factors that you need to account for before you do that. With a TIA, you give them aspirin for 14 days. So you give them high dose aspirin, so 300 milligrams, and then make sure they're seen in a TIA clinic within a week. You'll do an MRI to see if there's any kind of residual effects. Do a carotid ultrasound to see if that might be a cause for this TIA, and just secondary prevention is just putting them on just a normal dose of aspirin of 75 milligrams if they've confirmed this. Oh, and that is the end. So thank you guys. I'm really sorry it was a bit rushed there. But if you do have any questions, pop it on the chat. I'm sure Neil will pass that on to me. If not, I did put my email up on the slides as well. So feel free to email us too.
Okay, I'll start off by introducing myself. Hi everyone, my name's Ganesh. I just finished final year at George's. So I'm hoping to make this as applicable to your syllabus as possible. All right, so first of all, well done for being here at this time of the hour. I'll be going through audiology and ophthalmology. If you have any questions, just please put in the chat. Okay, take it away. All right. So essentially, to start with ophthalmology, we'll be kind of doing an overview of the anatomy, including the cranial nerves, talking about the physiology of the sight, and then reviewing some common and high yield topics such as glaucoma, cataracts, visual field defects. These are things that are going to, one, come up in your written exams, and also in maybe not this year's OSCE, but next year's OSCE, definitely things you kind of need to be proficient with. Okay, so in terms of the eye anatomy, you don't need to memorize this, but there's certain aspects of this that you kind of need to appreciate, and it helps you understand pathology. And it's better to link this anatomy with some clinical problems that we see. So to start off with, we have the cornea. That's the outermost part of the eye. It's the gel-like substance, and it sits in front of the eye. Yeah. And then you have, so the colored part of your eye, whether it be blue, brown, green, whatever, is called the iris. What sits and in the center of it is your pupil. Okay. And then you have your, if you can see this kind of large gray like egg structure, that's your lens. And then above and below it, we have the ciliary body. You can see these string-like things that are going from the ciliary body to the lens, and these are called your suspensory ligaments. Okay, so let's start putting this all together. One of the important things you really need to understand is that the anterior chamber and posterior chamber of the eye is pretty straightforward. From the cornea to your ciliary body, so essentially just behind the iris, that pink like structure, that's your anterior chamber. From there, behind is classed as the posterior chamber. Now that's really important to kind of understand, and the reason will come apparent as we go through this lecture. So when we're talking about ciliary body, it's got these ligaments, and these are what allow you to kind of, when I say accommodate, it's, you know, if I'm to read a book or look further in the distance, how I'm able to do that is the ciliary body will adjust the lens. And I think it's good to appreciate that when the ciliary body is contracting, the ligaments holding the lens, they actually relax. Yeah, so they work almost in opposite. So the ciliary body contracts, the suspensory ligaments relax, and the lens will change shape to accommodate. Now looking at okay, so if we go to say the retina now, so you can see there's 3 layers in the posterior chamber. So the retina, and if you follow the retina around, you can see something called a macula. So the really important thing to remember a retina here is it's concentrated with kind of photoreceptors. There's 2 types of photoreceptors you need to be aware of. They're called rods and cones. Rods are present predominantly in your retina, and they function with low level light. So what I mean by that is your ability to see in the dark is governed by the rods, and they are predominantly on the retina. The macula, which is that slight indent there, that contains cones, and it's very, very dense cones. Cones are involved in your color vision. So the wave spectrum of color, red, blue, green, everything between, they're predominantly concentrated in the macula. Yeah. So if you see people with a color vision problem or something like that, you think, okay, this is to do with the cones, and the cones are predominantly located in the macula. Yeah. So night vision is your rods, predominantly located all over the retina. Cones is your color vision, and they're densely placed in the macula. Yeah. Okay. And yeah, I think, you know, that's pretty much what you need to know at this stage. I am going to talk you through, let's see, yeah. So your pupil is dilating constraint, as you know. Cranial nerve 3, which I'm sure you all know is the oculomotor nerve, it's involved in the dilation and constriction of your pupil. And this is something I remember being asked in one of the exams. So your sphincter muscle, which is a circulating kind of muscle, that constricts the pupil. Your dilator pupillae, which is actually, it's also called the radial muscle, that dilates the pupil. Now, you know, if the question was worded in such a way, but the key thing you can think about is if the pupil is dilated, this is sympathetic innovation. If you think back to hunter-gatherer times, you know, if you're in a wild plain field somewhere, you need your eyes fully dilated. You need to be looking around. to see any sorts of kind of danger. So you dilate your pupils, maximum light is allowed in, and you can see around you. That's sympathetic innovation. Whereas the opposite, if your pupil is constricted, less light gets through. Your brain saying your vision doesn't need to be as acute, and that's to do with parasympathetic innovation. These are all controlled by cranial nerve 3, but there are branches of sympathetic and parasympathetic. And then you can see at the bottom of this picture here, the ciliary muscle. And we discussed how the ciliary muscle is what pulls the suspensory ligaments, and that changes the shape of the lens. Okay, so there's only one other thing I think is very, very useful to know about cranial nerve 3 in terms of its function here. Cranial nerve 3 helps to keep your eyelids open. So for you to open your eyelids, you're requiring the use of cranial nerve 3. Yeah. So, okay, the next thing. Okay, so we have, this is quite a kind of heavy slide, but I'll try and break it down. Essentially, each of your eyeballs has 2 visual fields. You have a temporal one and a nasal. And yeah, so essentially, if you're kind of able to follow the green and red line down, you'll notice that just the nasal fields, they cross over at what is termed optic chiasm, and they switch over to different sides from then on. So between the eyeball and the optic chiasm, we call that the optic nerve. Then we get to the optic chiasm, and if we come back from the optic chiasm heading further towards the occipital lobe, we call that the optic tract. Now, the reason that's important is when we're thinking about visual defects. If there's a visual defect in just one eye, then you know it's basically in the optic nerves. It's in front of the optic chiasm. When there's a defect in both eyes, it can only be at the optic chiasm or behind. And the reason is, at optic chiasm, we're crossing pathways. So the 2 eyeballs, their pathways are being crossed and shared. So when you get a problem in both eyes, unless you get, independent lesions in the right and left in the kind of optic tract, but that's a tangent. You sort of know, okay, it's going to be the optic chiasm or behind. And I'll teach you a way of differentiating whether it's optic chiasm, whether it's optic tract a little later on. But just remember, if there's a visual defect in just one eye, you should be thinking about optic nerve. Okay. Now, another thing that's, I think this is probably the best slide for it. Okay, yeah. So you may have done in clinical skills, if you have done some of the cranial nerve examinations, you may recall doing the RAPD test with the little flash torch. So this diagram is sort of referring to that. So if you can see unfortunately, I don't know if you can see my arrow, but you can see the 4 small circles here at the bottom of this picture. So if you follow that blue line going from the temporal field down, what that blue line first goes to is something called the pretactile nucleus. That then has a red line going to a circle in front of it, and that's called the Edinger-Westphal nucleus. And this is when things get a bit more interesting. When a signal reaches the left side of the Edinger-Westphal nucleus, that would then innervate the right side Edinger-Westphal nucleus as well. And if you note, there's a yellow nerve coming off that. That's actually oculomotor nerve. So that's cranial nerve 3 there. Okay, and why is it you should be kind of appreciative of this? Well, when we shine a light in a person's, say, right eye, we'd expect it to constrict. But we know that the left eye also constricts. So they're working in tandem. So there must be a point of communication. And this is it, the Edinger-Westphal nucleus. Okay? So when we're doing that test, what we're testing for is the Edinger-Westphal nucleus. Is that working correctly? Is a light signal being received? So now let's quickly discuss why there's arrows at A and B and things. Say, for example, I shine the light in the left eye of this person, or say the right eye, because we've got the blue and orange there. Now, that person's right eye does not constrict. However, the left eye does. Because I have a consensual reaction, I know the light signal is traveling through the person's right eye, right? Because it's the optic nerve that carries it down to the pretactile nucleus, to the Edinger-Westphal nucleus. So if I get a consensual response, I know the optic nerve in the person's right eye is intact, but the right eye itself isn't constricting, which would tell me it's probably a cranial nerve 3 problem with the right eye, because what we said earlier was the constriction of the pupil, dilation of the pupil is to do with cranial nerve 3. So that's one of the reasons, putting the cranial nerves together and things, you can appreciate this a bit better. Yeah, okay, so that's kind of what you need to know about that. Coming onto this now, so visual field defects. Okay, I think what I'm going to do is try and teach you my 3, I call it golden rules, it's just 3 rules really. Okay, so let's look at, say, B. When we look at the lesion where B is placed, you can see it's in front of the optic chiasm. It affects the right side. And if we look, there's vision loss on the right side. And as we said, if it's in front of the optic chiasm, it will just affect one eye. If it's at the optic chiasm or behind, both eyes are going to be affected to some degree. Why is that? Because at the optic chiasm, you're crossing over fibers from each eye. Okay. Now, so the first rule, if it's one eye affected, in front of the optic chiasm. The second rule, if both eyes are affected, either optic chiasm or behind. Now, the third rule is going to help you differentiate whether it's optic chiasm or behind, and we refer to that as the optic tract. So the third rule is this. If the visual field defect that you see is affecting the same side, so by that, if we look at D, we can see D, G, and H. You can see the left side of vision in the right eye and the left side of vision in the left eye is affected. We call that a homonymous heminopia. So when it's the same side, then we say it's the optic tract. So if the left side is affected, so it's a left side vision defect in each eye, we know it's a right-sided optic tract problem. Yeah. Now, the optic chiasm, however, because you get this crossing over, you get something called the Bi-Temporal Heminopia. The way to see this is it's the left side of vision in one eye and the right side of vision in the other eye. That sort of visual field loss only happens at the optic chiasm. So when we see that it's 2 different sides of vision loss, think optic chiasm. If it's the same side of vision loss, think optic tract. If it's just in one eye being affected, optic nerve. Yeah. There is some other things regarding, E and J, where it's a quadrant in superior aspect. I don't think at this stage you need to know this. I'll just run over it very quickly. But the way it works is if you have a superior left-sided visual field loss, then it's an inferior right-sided problem. And that's to do with the way the tracks are run. But I don't think that's really what you need to focus on. It's just the 3 rules that we discussed. A really, really common exam question will be a patient with bitemporal heminopia one of the common causes of this is a pituitary adenoma, so a pituitary tumor, and that lies the pituitary. I think it's I'm not going to pronounce it, but it's basically this Turkish saddle where the pituitary sits, and that's just underneath the optic chiasm. So, pituitary adenoma grows, presses on optic chiasm, and you get this bi-temporal heminopia, and it's very, very high yield for the exams. Okay, moving on. Okay, so now we come to the cranial nerves. Okay. This chemical formula, if you can remember it, I'm sure you can. LR6, SO4, R3. Lateral rectus is cranial nerve 6, superior oblique cranial nerve 4, and the rest is all cranial nerve 3. Okay, so let's break this down. Unfortunately, I don't think we do have a picture. Okay. Yeah, I think it'd be a little bit better to teach it this way. So, the superior oblique, SO4, the job of that is, it says superior oblique, but the way the muscle runs through around the eye is, its action is actually to pull the eye down and inward towards the nose. Yeah. And the lateral rectus will just bring the eye out towards the temporal region. Now, the superior oblique, to actually test the superior oblique, you can't just ask someone to just look down towards their nose. That wouldn't be testing it. What you need to do is, again, if you've done the cranial nerve exam, we ask the patients to follow our finger while we draw a H. The superior oblique is activated when the person is looking laterally. So let me just turn on my camera for this actually. Okay, I don't know if you can see me. Essentially, you want to look to one side, and when the eye is looking at when it's its furthest point in the temporal region, looking down, that is when superior oblique is being used. Okay. If you just ask someone to look down while their eyes are in the mid position, that's just using the inferior rectus, and that's controlled by cranial nerve 3. So if we go back to this picture here, you can see you get your medial rectus, lateral rectus, and then you have your superior rectus and inferior rectus as well. The superior oblique is only activated when they're looking in the lateral. So, if I ask someone to look furthest to their right, it would mean their right eye, if they're looking down, is using superior oblique. However, their left eye, that's actually in the medial aspect, isn't it? Because it will be looking towards their nose. That's going to be using just the inferior rectus. That's why when you do the H, you can test all the muscles. I can appreciate it might be a little bit harder to understand without a kind of visual input for this, but if you watch a video on the H being demonstrated, you start to kind of understand this a bit better. Just to tell you, the classic kind of George's thing is the whole eye that's down and out. Let's just go through this. So you can see cranial nerve 3 palsy. All of the inferior oblique, inferior rectus, superior rectus, medial rectus, they'll all be knocked out. What you have then is unopposed lateral rectus and superior oblique action. So if you have unopposed lateral rectus, that means it's going to pull the eye towards the okay, so this is affecting the right eye. So the right eye is going to be pulled out towards the temporal region, and the superior oblique, we said it actually pulls the eye down and slightly in. So when we look at the person, say we ask them to look straight, what happens to the right eye? It goes all the way to the temporal region and it's kind of sitting down, isn't it? And that's because of unopposed lateral rectus and superior oblique. It can be masked. If you ask them to look right, you might not notice it as much because, well, the lateral rectus is active. However, you can still appreciate that subtle difference. That's just because the superior oblique is working unopposed, the eye is still kind of sitting quite downward. Whereas if you look at the left eye, you can see kind of more of the actual iris. Yeah, so that's the classic down and out. Looking at a cranial nerve 6 palsy, 4 palsy. So that's your superior oblique being knocked out. So if you got to think about it as, if the superior oblique is knocked out, what does superior oblique do? It brings the eye down and slightly kind of inward. So you can see then, if you ask them to look straight, so if you ask the patient to look straight, you notice that the right eye actually sits, well, the actual iris is kind of sitting slightly higher. Why is this? Because the superior oblique is knocked out. It's not able to kind of bring the eye down and slightly inwards. So it's always sitting a little higher. When you ask them, yeah, I think so, right eye, yeah. So when you ask them to look, what does it say? Sorry. Yeah. So when you ask the patient to look left in the cranial nerve 4 palsy, you notice again the eyes aren't level. And again, same rationale, superior orbital, superior oblique has been knocked out. And lastly, cranial nerve 6 palsy. So your lateral rectus is now being knocked out. So if you ask them to look straight, the right eye is actually going to be pulled immediately. Why is that? Just have a think about it. So again, it's the medial rectus, which is controlled by cranial nerve 3, is unopposed, because to look straight, you need your lateral rectus and medial rectus to kind of be working in tandem. You've knocked out the lateral rectus, so the medial rectus is kind of pulling it all the way inward. So they're asked to look straight, and the eye, left eye is unaffected, so it sits fine. The right eye is affected. It's actually going to be pulled in quite a lot. And if you want to test it further, you can ask them, okay, look to the right. That the lateral rectus will bring it out towards the temporal region. In this case, they will be unable to do that. Yeah. So just go over this, and I think once you start to think about how the muscles work as kind of pairs to keep the eye level, if you knock one out, yeah, it should go the other way. It becomes a lot easier. So what do we have next? Okay. All right. So that was the heavy stuff. That was the kind of, think a bit more abstract. So now we can go with glaucoma. So the first thing to kind of understand with glaucoma is it's basically a collection of eye conditions that result in destruction or damage to optic nerve. It's not about having raised intraocular pressure. You can have glaucoma with a normal intraocular pressure. Normal intraocular pressure sits around 20 to 23. Yeah, I don't know if it's millimoles of mercury, but it's 20 to 23 is the kind of pressure. And there's two types of glaucoma that you should really be familiar with: acute angle glaucoma and open angle glaucoma. These are definitely going to be examinable. I would be highly surprised if it doesn't come up in this year's exam. There's one thing I do want to, let me see if I can just flick back very quickly. So if you remember, from the cornea down to ciliary body is your anterior chamber, ciliary body behind is your posterior chamber. I said that we're going to raise the significance of that. Your posterior chamber has a ciliary body that produces something called the aqueous humor. That aqueous humor flows from there into the anterior chamber, and it gets drained away by something called the trabecular meshwork. Now, if we, yes, okay. So the ciliary body, you can see an open angle where the arrows are. So it gets produced in this posterior chamber. It flows happily over to anterior chamber and gets drained away in the trabecular meshwork. Now, your eyes do require like the 20 to 24, 23 pressure. That's its optimal. It doesn't really have a great deal of it doesn't really have a great deal of kind of flexibility like, say, the blood pressure does. You know, going above 24 into your 30s or something, that will cause pretty significant damage to the optic nerve. So this is quite a finely tuned system where, you know, the ciliary body will produce a certain amount of aqueous humor, and that same amount is drained away from the trabecular meshwork. Now, this aqueous humor, why is it produced? One, to maintain the kind of shape of the eye. The second thing is your cornea, if you notice in the picture, it's a clear gel-like substance over the front of your eye. It doesn't have any blood vessels, because if it did have blood vessels, that would actually obstruct your vision. So part of the role of the aqueous humor is to provide nutrients such as glucose and some other kind of nutrients to the cornea, because the cornea is avascular. The second thing it does is it helps to kind of lubricate part of the lens as well. Now, so in open angle glaucoma, this is usually something that happens over time. It's a chronic condition. It tends to be that either the ciliary body is producing too much aqueous fluid, or the trabecular meshwork isn't draining that as quick as it should be for whatever reason. Again, this can be managed with medication. It's not usually a medical emergency. The difference, however, is in closed angle glaucoma. This is an acute condition, is a medical emergency because there's a high risk of permanent vision loss. And it's extremely painful as well. But the problem with closed angle is essentially the angle between the ciliary body and the actual lens, that's being closed off. So the fluid that's being produced by the ciliary body now, it can't actually travel into the anterior chamber. It starts to build up in the posterior chamber, and very quickly the intraocular pressure starts to raise, and that will very, very quickly start to cause damage to the optic nerve. Yeah. The classic kind of scenario you may see is, you know, somebody goes into somewhere like a cinema or something where it's a bit low level lighting, but there obviously is a screen there. So what your eyes will do is your pupils will dilate because they want to maximize the amount of light coming from the screen in so they can better see. That dilation of the lens, if you can see in the picture, can sometimes lessen the angle between the ciliary body and the lens. And it's a problem when the lens kind of gets stuck in its place, or, you know, something malfunctions and the lens is kind of stuck in a place, and that angle is now very, very kind of heavily reduced. And you start to develop this closed angle glaucoma. So the closed angle glaucoma in summary is to do with a reduction in the angle or the passage of fluid. With the open angle glaucoma, it's nothing to do with the actual passage of fluid being obstructed by the angle. It's to do with either an increase in fluid production or decrease in fluid drainage, or possibly a mix of the two. Closed angle glaucoma, medical emergency. Open angle glaucoma, it's still important, but somebody is probably not going to come to A&E with it happening within minutes to hours as open angle. Okay. Just to summarize closed angle glaucoma as a clinical presentation, extremely painful. They will have a red eye. There will be photosensitivity. The reason they have photosensitivity is because that lens is now kind of stuck in place. The pupil is quite dilated as well. So they can't, if it's a bright light, you would imagine the pupils constrict, but in someone with closed angle glaucoma, that pupil can't really move as freely because the ciliary body is stuck in place. So they're going to have some massive sensitivity to light as well. And again, it's acute. This would have happened over seconds to minutes. The next one, some of you may be aware, cataract. So as you get, the normal process of aging, people do tend to develop cataracts. What is a cataract? It's essentially a build-up of, it's a build-up of like debris. Multiple components, but it's basically small debris that builds up over time. When enough of it builds up on the lens, it starts to form what we call a cataract. The kind of most simplified description of this is if you imagine a clear glass window, that's what you start off with in life, and that's your lens. As you age, debris starts to build up on this clear glass window, and your vision starts getting impaired. What are some of the kind of features of a cataract? It's painless, it's generally bilateral. You have reduced visual acuity because if the light is being shone through a window that's got debris slightly placed upon it, you get less light coming through. The refraction of light has changed, so your vision is going to drop off. And they get sort of this classic halos around lights. The reason is for, if you're to perceive, if you're driving, you see a headlight or brake light or something, that light refracts through your eye and it focuses on one place in the retina. For it to focus, it relies on your cornea and secondary your lens. If your lens has some debris buildup, when it passes through your lens, it's no longer going to focus on one area in the retina. It's going to kind of scatter. And that's what gives people this kind of glare and scattering of lights. Yeah. Okay. There's another thing you do need to be aware of. Old age is the biggest kind of contributing risk factor for cataracts. There are some really other important ones that you need to be aware of. Diabetes, smoking, steroid use, and UV exposure. So, that's why, maybe Gucci sunglasses, apart from being fashionable, are kind of useful. Protects you from the UV damage that can accelerate cataract growth. But other professions, if someone's working with those blow torches or arc lights, massive exposure to bright light, you often see they wear a kind of face shield with a tinted visor. That's again to protect them from the UV kind of exposure. So those are other risk factors. You may see in the question embedded, someone that's has diabetes, smoker, works as a works in metalworks or something, presents with vision loss, complains of scattering lights while driving at night, those kind of things. Okay, and this is, I always like to see pictures to kind of understand what the patient is experiencing. You can see, actually, living with cataracts is very impactful. And obviously now, in the current day, it's a 5 or 10 minute operation at times that can change it. You can take out the cataract, restore vision. It's massively life quality enhancing. And if in the image on the right, you can see this is probably a person that's had cataract surgery in the left eye, yet to have it in their right. But you can see how light can get through, and you can see it's not really a reflex, but you can kind of see how light can get through one eye. It will have great difficulty getting through the other, and how that will cause scattering. Okay, so that's the kind of end of the ophthalmology part of it. Does anyone have any questions at this current time? If not, I'm just be going on to audiology. All right, so audiology. Again, just a quick overview of anatomy. We talk about how the hearing kind of physiology works, and we'll look at some common conditions. Right. So I'd like to break down my anatomy in more simplest form. The outer ear runs from the tip of your ear, if you will, to the tympanic membrane, or the eardrum, however you want to call it. The middle ear is from the eardrum to the cochlea. Doesn't contain the cochlea, but to the cochlea. So eardrum to cochlea is middle ear. Your eardrum to the outermost portion of your ear is the outer ear. Anything past, with the cochlea and anything past that is considered your inner ear. Okay, so let's talk about, so you don't need to know this for any particular reason. It's more of a concept you need to appreciate rather than kind of being able to reel off. But so sound waves are essentially vibration. It's the vibration of air molecules. It enters the ear canal, it goes along, it makes contact with the tympanic membrane. So it starts to vibrate your eardrum. Those vibrations are then, it's like a domino effect. The malleus is the next, just behind the tympanic membrane. That starts to vibrate. That translates into the incus and then the stapes, yeah? So the stapes is actually connected to the oval window of the cochlea. And all it's doing is carrying that vibration into the oval window. And in the cochlea sits this kind of fluid. And what that is called perilymph fluid. But what that's doing is sending that vibration through the perilymph fluid. And if you can see, in this cochlea, there's like 3 layers. The central blue layer, that contains your hair cells, and it's connected to like a basement membrane. When the vibrations kind of go through and start to rock the hair cells and move the kind of basement membrane around, it causes a depolarization. So potassium, which is in the perilymph fluid, kind of flows into the hair cells, depolarizes them, and that sends off, so these vibrations that cause all that, when it becomes depolarized, an electric signal arises and goes to your auditory nerve. Now, the main things to appreciate from this is, one, the path of the vibration of air molecules hitting the tympanic membrane and so forth. The other thing is to know the bones, the malleus, incus, and stapes. So the malleus kind of sits on the eardrum, stapes sits within the oval window. In regards to the hair follicles, just because there is a condition we'll talk about and that involves them, so just to appreciate, the hair follicles are an integral part of sound being perceived. Now, when we look at this middle blue layer, if you took at the start of it, in the middle of it, and the end of the blue layer, the length of it, those hair cells, they all become depolarized, but they depolarize at different frequencies. So if you look at like the middle of this, the length of the blue layer, that depolarizes frequencies of sound at quite a high level, whereas the kind of end and the start of it, they'll depolarize at sound at different frequencies. Okay. Yeah, I think that's really all you need to understand about this, actually. Yeah, it's predominantly what you need to know. And you can kind of see in this picture, the vibration, it goes in the perilymph fluid through the oval window, and part of it will kind of exit out the round window as well. Because obviously you can't have pressure being translated into a kind of contained system. It needs the inflow and outflow. Okay, so bearing all that, what the main thing you need to take away is it's all about hearing loss. So these are my rules again. Conductive hearing loss. Conductive means how we said those all sound waves that travel into the air canal, they conduct on the tympanic membrane, and the domino effect starts to kind of conduct on the malleus incus stapes. This is all to do with conduction of the vibration, right? So a conductive air hearing loss only happens in the external or middle air. The inner air, being the cochlea and anything above that, they're not conducting sound anymore. They're actually interpreting the vibration of sound waves into an electric signal. They're not doing anything in conduction, the interpretation. So that's why conduction hearing loss is external middle air pathology. Yeah. Okay. Common things. So let's go with there are there's quite a few causes of conductive hearing loss, but I always like to nail down the top 3 causes, and usually the top 3 causes will account for maybe 85% or 80% of things. So with conductive hearing loss, I think these 3 are about 82% or something of the cause of conductive hearing loss. So cerumen impaction, fancy way of saying AOX, air barrel trauma. So that would include things that rupture the tympanic membrane, because if the tympanic membrane is ruptured, that thing is not going to vibrate. If the tympanic membrane is not vibrating, no vibratory translation will happen to the malleus incus stapes, right? So air barrel trauma, common things, diving, aeroplanes. So the reason, if you kind of remember, but the reason that aeroplane sort of, when it's coming to its cruising speed, the reason it does it slowly, one maybe to do with aeronautics, but one of the major reasons, if it were to directly go up to 40,000 feet, apart from the oxygen adaptation, the pressure difference, it will be so rapid that it can cause air barrel trauma, because your middle air and your outer air is separated by the tympanic membrane. They always want the pressure to kind of be equalized. If you go rapidly high up in altitude, your pressure is dropping. So your outer air has low pressure. The middle air hasn't had time to equilibrate. So the middle air is high pressure, and it will try and rupture through the tympanic membrane to equilibrate pressure. That's why in an aeroplane, it's kind of gradually going up. The same concept for diving, yeah. So that's air barrel trauma. Otitis media, essentially in the middle air, any kind of inflammation. With inflammation, you can get some pus. That will increase the pressure in the middle air. And again, the same kind of concept. It's if you've kind of increased pressure in the middle air due to pus, even if your tympanic membrane is vibrating along, that vibration is going to be heavily reduced in the malleus incus and stapes, because there's a buildup of pressure that's kind of oppressing some of the movement of those fine bones. Yeah? So these are the common things. Okay, so we've talked about conductive hearing loss. Now we're going to talk about sensorineural hearing loss. Sensorineural means the interpretation of the vibratory signals. So it could be the cochlea, because we've got the perilymph fluid, we've got the hair follicles, that's all in the cochlea. Or it could be the actual auditory nerve, which the cochlea kind of translates when the depolarization of hair follicles happens, turns into an electrical signal, sends it to the auditory nerve. So cochlea could be perfectly working very well. Auditory nerve, however, may be dysfunctional. So that's also comes under sensorineural hearing loss. So common causes, got presbycusis, which is a fancy way of saying age-related hearing loss. So as you get older, hearing loss. As you get older, the hair follicles in the ears, they start to become damaged, the natural process of aging. So that can cause sensorineural hearing loss. There's also noise-induced hearing loss, which again, it's kind of damage to the hair follicles because you're overstimulating them, especially people that work in high machinery, jackhammers, those kind of things. Meniere's disease, in very quick summary, it's basically the perilymph fluid, a bit like the kind of aqueous humor of the eye, where its limits are quite set. If you were to raise the amount of fluid there, the margin, even if it's a marginal increase, that has some severe impact on how it functions. So Meniere's disease is essentially there's more perilymph fluid in the cochlea than there should be, and that causes a disruption in the functioning of hearing. An acoustic neuroma is essentially a kind of benign growing mass. I think I may have a picture. Essentially, that benign growing mass presses upon the auditory nerve. Yeah. So let's think about ways of splitting this up. Acoustic neuroma, it often affects the facial nerve and the auditory nerve. So cranial nerve 7, facial nerve, cranial nerve 8, your vestibular cochlear nerve, they run basically adjacent to one another. So when you get an acoustic neuroma that's placing, impeding upon cranial nerve 8, it often hits cranial nerve 7 as well. So people will present with changes in hearing, but also changes to kind of their ability of facial expression, so raising their eyebrows, smiling, things like that. Okay, so presbycusis, so the age-related hearing loss. So this is the most common cause of a sensorineural hearing loss, so something we really do need to go over. As I said before, it's irreversible damage to the hair cells of the organ of corti, particularly at the basal turn of the cochlea. So it's like the basal turn is essentially the mid part of the that middle blue line we talked about. And if you remember, we said each part of that blue kind of inner line, the hair cells translate sound at a different frequency. So the ones in the middle near the basal turn, they actually are responsible for translating sound at a very high frequency. Just like happens in presbycusis, the damage that happens to the hair cells predominantly are in that area. So you're knocking out high frequency really. So that's why high frequency is impaired in presbycusis predominantly. Of course, it's bilateral and progressive. And a really common thing they'll kind of quiz you on is, so in sensorineural hearing loss, hearing is worsened in noisy environments, right? So you've got some impediment to the translation of sound, whether it be in the nerve or the hair follicles. If you're increasing the amount of vibration and sound coming through the air, as you would in a noisy environment, the hair follicles, they can't translate as efficiently because there's a lot more vibration going on, and the auditory nerve, if there's a problem there, it's getting a lot of signals being fed into it, so it's harder to distinguish sounds as well. So that's why hearing is worsened in noisy environments. Whereas if we contrast that with a conductive hearing loss, so earwax buildup, for example, in a noisy environment, you're getting a lot more frequency. Yeah, so frequency is just simply the number of kind of wave cycles of sound that come through per second. So you've got some earwax buildup, but now you're, instead of getting 50 hertz, which is the way of measuring frequency, you may get 150 hertz. That means that more sound waves will probably get through some of this obstruction of earwax, and therefore the hearing actually improves in noisy environments. So when it's a conduction problem, something with earwax, we improve in noisy environments because you're getting a little bit more of sound waves kind of able to overcome some of the obstruction or get around it. Whereas when it's a nerve damage problem, that's going to have a counter effect. And that's really a common thing that will come up in exam questions, that they state, even if you're unsure of what's happening, if they state hearing is improved in noisy environments, you should be thinking, okay, this is something conductive. So, and then, you know, think about outer ear, middle ear. Now, just very quickly, audiograms, they probably will come up in the exam. What I'm going to teach you more just about a normal audiogram. I don't think we'll have time to go through everything, but a normal audiogram would mean that. So let me see if I can get the legend. Okay, so your air conduction and your bone conduction, they should be pretty similar throughout. There shouldn't be a difference greater than 10 decibels in between where their dots are. And so that's a normal audiogram. They kind of run together. There's not much difference. If you start looking at conductive hearing loss, for example, conductive is relying on air, isn't it? Because it's the air molecules being vibrating, passing through your air canal, hitting the tympanic membrane. When we look at conductive hearing loss, you can see that there's a huge difference. It's more than 10, it's almost 30 at certain points, right? So you can infer, hold on, it's air conduction that's being affected. Air conduction is a conductive hearing loss problem. There is also, you know, the sensorineural hearing loss, conductive hearing loss due to otosclerosis. So, okay, so the key thing here, when you look at conductive hearing loss with otosclerosis, it's something called Carhart's notch, and it happens at 2000 hertz frequency. And you will see there's this a massive dip. But that's I think audiograms is something you guys should definitely go back and just read up on. I don't want to spend too much time on it, but if you can understand what a normal audiogram is, and then you know, when bone conduction or air conduction is affected, for otosclerosis, is that Carhart's notch is really high yield. So just to be familiar with it, read around that. Okay, what's next? Okay, so Renee's test. Renee's test, you may have done it by now. Place a tuning fork, 512 hertz tuning fork, I think we used. You activate it, you place it behind the ear in the mastoid process. And you can ask them, when they stop hearing it, you then bring it to the front of the ear and, you know, get them to listen to it. And what you're asking them is, does it sound louder in front or behind? Now, air molecules are disrupted. They're a better conduction of sound than bone, right? So air molecules are free flowing. So you would expect that they can hear louder in front than behind, because in front relies on air conduction, whereas behind relies on bone conduction. Air molecules flow far easier, so you'd expect them to hear things louder in front than behind. So if that's the case, it's really positive. If they say they hear it louder behind than in front, it's really negative. Then you've got to think, okay, if they're hearing it louder behind than in front, there must be something impeding the flow of sound waves in the air. And again, you think, all right, conductive problems. Is it earwax? Is it Otitis Media that's kind of built up pressure in the middle ear as the tympanic membrane ruptured? So that's what Rinne's is testing. You're testing whether air conduction is better than bone conduction in the ear. You then move on to Weber's test. Weber's test is almost like a confirmatory sort of test, right? And again, you activate your tuning fork, you place it in the middle of the forehead. Now, in a normal person, the sound should be equal in both ears. And the reason is, when you activate that tuning fork, they get air conduction on both sides because you can hear some of the vibration. But because it's placed in the forehead, you also get bone conduction. Now, there's a really important thing to note here. If I, for example, had conductive hearing loss on the right side of my ear, so let's say earwax is built up in the right side of my ear, what will happen is I actually hear the sound louder on my right side. And the reason is the left side of the ear, where there's no earwax, is receiving some sound running through the ear and the rest through the the feeding of the bone. But the right ear that's got earwax built up, it doesn't have any kind of audio input via the ear now. So it's not being kind of distracted from any air molecules running through the ear canal. All of the signal is actually being taken in from the bone. And because it's taken straight in from the bone, it's like there's no distraction coming from the air molecules entering the ear canal. It's all being received by the bone. So the right side perceives the sound as louder because there's no distraction from the air molecules due to earwax buildup. Whereas the left ear, it has some kind of distractory noise from vibration, and it's also receiving the bone conduction. So that's if it's conductive hearing loss. But say if it's a sensorineural hearing loss. So let's say the right side of my ear, the auditory nerve is non-functional. So when you activate this tuning fork, I'm going to hear it a lot louder on the left side. But in this case, it's because the right side, there's no auditory nerve functioning, or the cochlea is damaged, or anything that gives rise to sensorineural hearing loss. If the right side can't perceive sound, I'm definitely going to hear this louder on the left. But that's why we're taught to do Rinne's first and then Weber's, because Rinne's will be telling you whether this person has a conductive or sensorineural hearing loss initially. So if you do Rinne's and they've got bone conductions better than air conduction, you can think about, oh, it's a conductive defect. And then if you do Weber's and it lateralizes to the side with a conductive defect, it kind of confirms it for you. And this chart will hopefully summarize. So Rinne's, we expect normal is air conduction better than bone conduction, whereas heard in midline. That's fine, that's normal. Conductive hearing loss, because your ear canal is blocked, bone conduction will be better. The Weber's will be heard in the bad ear. Again, because air conduction is kind of blocked, there's no distractory noise. The bone conduction is heard better in that ear. And then what happens with Rinne's is air conduction is greater than bone conduction in the sensorineural hearing loss. And that's because bone conduction works on directly kind of stimulating the organ of Corti and some of the auditory nerve. So you can't amplify sound, bone conduction. Whereas air conduction, your tympanic membrane is very large compared to the stapes that sits in the oval window. Because of that size difference, we're kind of actually amplifying a lot of the sound. And that's why when you get sensorineural hearing loss, if the organ is slightly damaged, because air conduction amplifies, it will still be better than bone conduction. Bone conduction doesn't work on amplification. So you might say, okay, air conduction is better than bone conduction in Rinne's. That's fine. That's what I would expect in a normal person. Great. You go on to do Weber's, but then Weber's actually lateralizes to one side. Now you wouldn't expect that. You wouldn't expect that because you may think air conduction better than bone conduction in each ear or one ear. That's normal. But because Weber's is lateralizing to another side, you need to think that actually there's a sensorineural hearing problem in the side it's not lateralizing to. Because that can't hear and pick up and translate the vibration from the Weber's test as well as the other ear. Okay. Any questions? Okay, so let's go into some questions. I'm just going to check. Should be. I hope we're okay just to move into questions. Okay. I'm not sure if you guys log into Vivox and do these questions.
Yeah, you should all already be logged in. But let me know in the chat if there's a problem, and I'll just open the polls when you want me to, Ganesh. Unless you're on it. You're not logged in, are you?
I don't think. No, I don't think I am.
I can open them for you.
Okay, if you. Thank you. Yeah. All right. So I'm hoping these pictures are nice and clear. So which cranial nerve has been affected?
Poll is open now.
Okay. Thanks, Nia.
No worries.
So just a reminder, in the picture B, the patient is being asked to just keep his eyes open, look midline. So just, you know.
Also give like 5 more seconds.
All right, I think that'll be it. Okay, so
Yeah.
close the polls.
Well, so the majority went for A.
All right.
It's a bit of split between A and C.
Okay, so just to summarize this, to keep your eyelids open, you require cranial nerve 3. So in the picture B, you can see they're being asked to look directly ahead, eyes open, and the eyelid is shut. I mean, you could argue, oh, you know, maybe they're being asked to close their eyelids, but if you link it to the picture A, where one eye, remember eyes work in tandem, right? They work together. So if one eye is looking straight ahead, the other eye should be doing the same. But if you look, the left eye of this gentleman is definitely outward and it's slightly down, because if you look at the level, so if you just look at the pupil level, they're not aligned. The left eye is definitely lower and slightly outward. So you start to think that's where the down and out comes from. Yeah, it's outward towards the temporal regions, that's lateral rectus, and it's kind of downward moving, so your superior oblique. Yeah. So that's why it's cranial nerve 3. Okay, question 2. A patient visits the optometrist due to a decrease in vision. He states that his vision is particularly bad during the night, and when he's driving, lights appear scattered. He states that this has been getting worse over the last year or so. What is the most likely diagnosis?
Open.
So polls open, please.
Yeah. So I'll give 5 more seconds because I think most people have answered now. Cool, I'm gonna stop it now. So it's split between B and C, but majority B.
Okay. So yeah, the majority you are correct. So the key thing here that kind of lends you towards cataracts is this scattering of lights. Because remember, when the lens becomes clouded in cataracts with this kind of debris, light can't travel. So light in a normal setting travels through in one path, goes through the lens, focuses on retina. When you've got these little debris build up as you do in cataract, when light passes through, it doesn't pass through as one singular light path anymore. It starts to break into little different light rays hits the retina, and that's interpreted as scattering of light. You don't see that sort of thing in glaucoma. Okay, so question 3. A patient attends A&E with a sudden onset unilateral red and painful eye. Considering the most likely diagnosis, what are the clinical features would you expect to find?
Poll is open. Give it. Okay, I think everyone has voted now. So everyone went for A.
Fantastic. Okay. Yeah, that's exactly it. So you fixed dilated pupil and light sensitivity. Again, because the pupil has kind of is dilated essentially. So even with normal or bright light, it can't constrict to reduce the light coming through, and you get the light sensitivity. Okay. What is the visual defect that we're seeing here? So just, I know it's on a white background, which wasn't too smart of me actually, but you're seeing in each of the eye, the left side of the vision has been impacted.
Poll is open. And I think everyone has voted, so it's a split between B and C, with majority going for C.
Okay. All right. It's probably a bit of a harsh question, to be honest. So let's go through our 3 rules again. So it's affected both eyes, so it can't be an optic nerve issue. The optic nerve runs from the eye to the optic chiasm. When you get to optic chiasm, you run behind towards the occipital lobe, you're dealing with the optic tracts there. If it's an optic nerve problem, it's only one eye that's affected. So both eyes are affected here. So we know it's either optic chiasm or optic tract. I do apologize. I know that the difference between tract and optic nerve, there's not much in it, but that's just how they refer to it. And then the second thing is, let's look at the visual defect. It's on the same side in each eye. It's both left side in each eye. So we know it's an optic tract problem. An optic chiasm, it will be different sides. So it will be left side and right side. Okay. So now we've identified optic tract. The next thing is both on the left side. So we know it's a right-sided problem. Because the signals switch over, and so if it's a left-sided visual field defect, it's a right-sided optical tract problem. If it's a superior visual field defect, it's an inferior kind of optic tract impediment. So sorry, a little bit of a harsh question there. But it's, once you do a few of these questions, you get used to the way of thinking about it. It is a bit difficult. Okay. Just an amendment on this question. So which of the following factors has the greatest influence on intraocular pressure? So the greatest influence on intraocular pressure.
Polls open. Cool. So everyone has voted and everyone's gone for C.
Perfect. Well done. All right, that's exactly right. Okay, great. All right, next question.
Cool. So everyone's voted and it's a split. So some B's, some C's, some D's, and some E's actually.
Okay. So conductive hearing loss. So it's not normal. So you only get Rinne's positive in your normal where air conduction is greater than bone conduction. If you have a conductive hearing loss, your air conduction will not be better than bone conduction. So Rinne's is going to be negative. So that's the first thing you need to think of. Then Weber's is going to lateralize to that air, because if you have conductive hearing loss, you're not getting the background distraction via the air canal. It's all coming via bone conduction. So it will be perceived as louder in that air. So it's going to be Rinne's negative, and Weber will lateralize to the right, because that's the right-sided conductive hearing loss. Yeah, I hope that's clear. It took me ages to get my head around this, but I think someone had said it to me as it sounds, it will sound louder in the right, the air with the conductive hearing loss, because the air is not being distracted by the background noise via the air canal. So that's why it's louder on that side. Okay. A little bit of a harsh question, I think, but just in audiograms, again, so if I explain this as both ears are being affected, just trying to have a go. It is a very difficult question unless you've kind of gone through audiograms in some of your previous lectures.
Cool. So everyone's voted and has gone for D.
Perfect. Yep, exactly. So both ears are affected. It's at high frequencies, and that's what you see in presbycusis. Right, perfect. Oh, last question. Yes, last question.
Cool. So everyone's voted and it's a split between A and B, but majority A.
Okay, so yeah, the majority are correct. Hearing aids, put simply, they amplify sound, a bit like your tympanic membrane. So hearing aids, they amplify sound, whereas the cochlear implants, they actually bypass the tympanic membrane or the bones, and they directly take, the vibratory signal, and they innervate the nerve directly. Yeah. Okay. Well done, everyone. Sorry, I think I've run over a little bit, but well done. Any questions or?
Then we can get through. So I'm Ellie, I'm an F1, I worked down in Devon, and I went to uni with Anaya and Ash, and today I'm going to be talking about Parkinson's disease. So I should be able to go over this in 15-20 minutes. Let me share that. Can you all see my slides?
Yeah, you can see them.
Perfect, great. So Parkinson's disease, so a quick overview. So it's a chronic progressive neurological disorder, and the onset's insidious, so it comes on over sort of months really, and it's often asymmetrical. And we're going to talk as well about Parkinson's disease, the condition itself, versus Parkinsonian features, because there's a lot of other conditions that mimic Parkinson's disease with similar presentations. So does anyone know which area of the brain is affected in Parkinson's disease? I'll give you a little bit to answer that.
Polls open. Do you have access to the polls, Ellie? Or
I
did we
don't
put it out?
know.
Cool. No, don't worry, just checking. So I'm going to give it 10 more seconds.
Yeah.
Cool. I'm going to close the poll now. So C is the majority.
Fantastic, well done, guys. So yeah, it is C. So this is your basal ganglia and surrounding structures, and we're going to go over that in a bit more detail in a couple of minutes. And can anyone just pop in the chat matching the letters with the numbers here? Okay, or even just one or two of them. Perfect, thank you, Jason. Yeah, that's great. So yeah, so D is 4, you're right, and C is 2. And then your brainstem controls your respiration, autonomic function, and your cerebellum controls mainly balance and coordination and your posture. So here's just a brief overview of your basal ganglia. I always feel like when I'm giving a lecture on neurology, you could probably write a textbook on the content of just one of these slides. But just for the purposes of this topic, your caudate nucleus is involved in planning and execution of movement. It's also got involvement in learning, memory, emotion and motivation to do different tasks. Your globus pallidus is split into your interna and externa, and this is involved in regulation of voluntary movement. The putamen is responsible for learning, motor control, articulating speech, and also is involved in addiction. And then your amygdala and the thalamus are sort of related structures to the basal ganglia. And your amygdala has a big role in anxiety and threat detection. And your thalamus is a bit like a relay station. So all of the motor and sensory functions within your brain pass through the thalamus. And then I think Ganesh went over this already, but cranial nerves, here's just a brief overview of your cranial nerves and some good ways to remember these. We learned some slightly more rude ones in medical school, which is probably not suitable for this presentation, but I found a good sort of clean mnemonic for the cranial nerves. For the names, only one of the 2 athletes felt good, victorious and healthy. And then functions, so some say marry money, but my brother says big brains matter most. Whenever these words match up with the numbers of the cranial nerves, and if it's S, then it's a sensory nerve. If it's M, it's a motor nerve. And if it's B, then it does both. It's quite a good one to note down for your exams. Okay, so what is the function of the direct basal ganglia pathway?
Polls open now. And everyone's been really speedy on this one and said A.
Great. Yes, perfect. So your basal ganglia are in control of your movement. So the basal ganglia are a collection of nuclei, and their job is to make movement and also to prevent unwanted movement. This is driven mainly by two neurotransmitters, and that's GABA, which stops things from happening, and glutamate, which starts things to happen. Your direct pathway controls making voluntary movements, and your indirect pathway stops involuntary movement. And here we've got the really tired doctor in the direct pathway wanting to reach for his coffee. And on the bottom, we've got the man who is really, really angry at his computer, but doesn't really want to throw it out of the window. And you've got both those pathways in action there. So your thalamus, this was taught to us in medical school, as the thalamus is like a dog on a leash. So it always wants to go. So at any one time, the thalamus is inhibited. And the direct and indirect pathways both work by releasing that inhibition on the thalamus, which allows it to move and send signals to the cortex. So we'll go through in a second. So here's a good overview that I found of your basal ganglia. So your indirect pathway, your cortex sends sort of excitatory signals to the striatum, and you've also got dopamine stimulating from the substantia nigra. This in turn then inhibits the globus pallidus externa, which then inhibits the subthalamic nucleus, and this then excites the globus pallidus interna. Then this releases the inhibition on the thalamus, and the thalamus is free to send its signals to the cortex. And a slightly different pathway for the direct side of things. So the cortex sends excitatory signals to the striatum. This is also influenced by dopamine from the substantia nigra. This inhibits the globus pallidus interna, which inhibits the thalamus. Inhibits the thalamus, which sends signals to the cortex. So this took me a long time to get my head round in med school. It's just something that you have to sit down and sort of go through and learn. But I thought this diagram summed it up quite nicely. So which neurotransmitter do you think is involved in the pathophysiology of Parkinson's disease?
Cool. So again, they've been very speedy and said C.
Brilliant. Yeah, well done, guys. So it's dopamine, and it's often sort of known popularly as the feel-good hormone. And does anyone know which of the following movement disorders is associated with Parkinson's?
So quickly again, everyone has said B.
Marvellous, great. So you know your Parkinson's very well. So bradykinesia is one of the three sort of key features of Parkinson's disease, along with resting tremor and rigidity. There's also what we call a Parkinsonian gait, which is kind of a shuffling, sort of low stepping gait, and it makes people a lot more prone to falling over. Mask-like features, they've got quite an expressionless face. Their movement is generally slower, and that's another way of saying bradykinesia, really. And they've often got quiet, sort of monotonous speech. And the slow movement affects things like writing. So they get sort of micrographia, where their writing is very, very small. And Parkinson's pathology is all related to a loss of dopaminergic neurons in the substantia nigra pars compacta. So that's just a point to remember for exams. So on examination of a patient with Parkinson's, we're looking for this pill rolling tremor. So it's a movement with the hand that looks like they're literally rolling a pill in their hand. And this is a resting tremor, and it ceases with active movement. So if you ask them to do something with their hands, the tremor will usually stop. However, it's not necessarily just a resting tremor. Patients with Parkinson's, particularly in later stages of their condition, can also have action tremors, particularly if you ask them to hold out their arms and spread their fingers apart. And they can also have problems with past pointing. They're often unable to perform rapid alternating movements, so you can just get the patient to sort of tap their finger on their hand, and they'll often find that difficult. We've mentioned the quiet voice, the small writing. They often have quite a stooped posture, and you'll also get this cog wheel and lead pipe rigidity. So cog wheel is as you've got the elbow sort of bent and you're holding the patient's hand, you try and move their hand around in a circle, and the arm will sort of jerk its way around, exactly like a cog wheel. And then your lead pipe rigidity is, again, you try and bend the patient's elbow, and it will sort of slowly be bending and then all of a sudden bend very quickly. And that is just a sign of the rigidity that comes with Parkinson's. So how do we diagnose somebody with Parkinson's most commonly?
So people have gone for D.
Yeah, it is D. So the only exception to that is if somebody is young, or if they've got sort of atypical features of their Parkinson's that might suggest that it's a different diagnosis. So there's lots of mimics for Parkinson's. People with Alzheimer's can have sort of some of the signs, but it's often accompanied by dementia and aphasia rather than quiet speech, so more like people not talking at all. Drugs can induce sort of rigidity and cogwheeling and things like that, particularly drugs that affect the uptake of dopamine. So metoclopramide is a big one, and we don't give that to people with Parkinson's for that reason. It worsens their symptoms. Also things like lithium. There's something called vascular Parkinsonism, which is basically tiny strokes that affect the basal ganglia. So it causes the same sort of symptoms, but it's often very stepwise and it's symmetrical. And if you try and start the patient on medication like levodopa, it doesn't respond. Also, Lewy body dementia has similar sort of Parkinsonian features, but patients will often hallucinate and have sort of a dementia and changing mental status. So how do we manage idiopathic Parkinson's? So the mainstay of treatment is carbidopa and levodopa. The brand name for this is Sinemet. You'll often see that on drug charts. And the point of giving the dual drug together is that levodopa is able to cross the blood-brain barrier, but carbidopa prevents it from breaking down until it's crossed the barrier. And then once it's past the barrier, carbidopa can't go across, but levodopa can. So then it breaks down and metabolizes to dopamine. Second line treatment is pramipexole, which is a dopamine agonist. So this stimulates the production of more dopamine. And then finally, we've got selegiline, which is MOA inhibitor, which breaks down. So MOA, the enzyme, breaks down dopamine. So the MOA inhibitor will stop that from happening. Does anybody know sort of a odd side effect of MOA inhibitors? Something that we have to warn patients about before giving them on? Oh, I saw somebody starting to type. Cheese, yes, cheese. Yeah, exactly, cheese. So there's a substance called tyramine, which is found in cheese and also salami and pickled fish and things like OXO cubes. And people on these type of drugs can have a really bad reaction if they eat those things. And you'll often see in hospital, they're really sort of strict on giving patients' Parkinson's meds on time, because any sort of delay, even 5 minutes, can cause their symptoms to come back very quickly. Other things that we can do for patients, so we can offer all the holistic kind of things, give them physio if they're, particularly with their shuffling gait, occupational therapy to minimise risk of falling, speech and language therapy, and there's also types of cognitive sort of rehab that we can do for patients. And then particularly in young patients or patients that are sort of refractory to medication, they are starting to do more of this deep brain stimulation, which sort of electrodes are placed in the brain and sort of stimulate the subthalamic nucleus and globus pallidus, and that can really help the symptoms as well. So what should patients be warned about when they're taking dopaminergic medications?
So everyone has gone for E.
Yeah, fantastic. Great, guys. So yeah, indeed, it's all of the above. So in med school, people tend to tell you about the compulsive behaviour, which, yes, it's very true. You need to warn people about that, but it can actually cause all of those symptoms. And so it's important to counsel patients before they start taking those. Great, so that's the end of my presentation. Does anyone have any questions at all?
So I'm going to be going through depression and dementia. I'm going to start off with depression, which weirdly actually starts off with headaches. So going through headaches, there are kind of two different ways of classifying headaches. So the first one is to split them up into either primary headaches or secondary headaches. And a primary headache is one that's due to the headache itself, and it's not because of something else. So examples are migraines, tension headaches, and cluster headaches. And then you've got your secondary headaches. So a secondary headache is a headache that is present because of another condition. So that's things like systemic infection, if you've got head injury, any kind of bleeds on the brain, space occupying lesions, just anything that's not just due to the headache itself. And then the other way of classifying headaches is to split them into how they started. So you can have acute headaches, which present in minutes to hours. And I've made this big table, but I'm not going to go through all of them just in the interest of time, but just to go through like examples of them. So acute headaches would be subarachnoid hemorrhages, which people often describe as this thunderclap headache. It feels like being hit around the back of the head, people say. And then you've got your meningitis, encephalitis, head injuries. Some drugs can give you acute headaches and infection as well. Then you've got your subacute headaches, which are kind of in between, so take a bit longer to progress. So that's things like intracranial mass lesions, temporal arteritis, sinusitis, and acute glaucoma. And then you've got your kind of longer chronic headaches. So they're things like the tension headaches, migraines, raised ICP as well can build up slowly, cluster headaches, and then medication overuse headaches as well. So first question, this is a bit of a two-step question. I think it's quite hard, but don't be discouraged. So Mr. Olsen is a 35-year-old who presents to you at the GP surgery complaining of severe headaches. He tells you that he's been having many of these throughout the day. He describes the pain as being around his left eye. During the episodes, his nose runs and his eyes get watery. Which medication may help to prevent further headaches? So A, sumatriptan, B, topiramate, C, verapamil, D, propranolol, or E, ibuprofen. Ooh. Gonna give maybe 5 more seconds. So I can see that everyone actually went for A. The answer is C, but I can see where you're going with A. So this is a summary of kind of all the different, well, not all the different types of headaches, but the ones that I think you should probably kind of know how to recognize and also probably know how to manage. So you're all, I think, right? If you were thinking cluster headache, that's what I was going for. So with the like lacrimation on the nose, it being around kind of one eye, they're kind of what fit with the cluster headache. And cluster headaches, my way of kind of remembering it doesn't help with my question, I'm afraid. But cluster headaches, my way of thinking about it is thinking of a cluster of mushrooms. And then if you imagine magic mushrooms, if you took some magic mushrooms, you get high, which is how I remember the high flow oxygen. And they might make you trip, which is how I remember the triptans. But that is only for the acute management of a cluster headache. Whereas if you want to prevent further headaches, you actually use verapamil. But I can see where everyone's going with triptans. And then the other two types, so you've got your migraines, which are usually unilateral. Just remember about kind of the prodrome. You can get this like preceding aura. The photophobia particularly is like classic of a migraine. And yeah, I'm not going to go through all the different things, but you're going to have this table to look at a bit later. You kind of just have to sit down and memorize these really. But it's not too long, and once you've done a couple of different questions, you'll remember easily. Cool. So there are some red flags of headaches. So they're just things to worry about really. And there's a mnemonic that can help you remember it, which is SNOOP. So the S stands for systemic signs and symptoms. So that's things like if they've got a fever with the headache, if they're losing weight, if they've got any signs of meningism, so the stiff neck, photophobia, rashes. The N is for neurologic symptoms. So if they've got any decreased level of consciousness or any kind of neurological deficit, so vision changes or sensory loss, and that's worrying. O is if it's sudden onset. So in a lot of cases, a sudden onset headache is probably the most concerning. O is if they're over 60. I think that probably mainly relates to temporal arteritis, and that's something that occurs usually in older people. And P is if it's getting progressively worse. And the other P, it's SNOOP with two Ps, is if the headache's positional. So if it's worse when they lie down or when they cough, then that's a bad sign. And now we're going to move on to depression. So just going to run through the kind of the main features of depression. So there are three core symptoms that define depression really. So it's low mood, anhedonia, and anergia. So anhedonia is when you don't enjoy doing things that you usually used to do. So when you're taking a history from someone with depression, it's good to ask about their hobbies and ask if they're still enjoying doing them. And then anergia is just lack of energy. But there are loads of other symptoms of depression as well. Those are the three core ones. But the other features, so you can get changes in appetite, leading on from that changes in weight, disturb your sleep, reduce libido. Cognitive symptoms can be quite predominant, so really poor concentration, feelings of guilt, hopelessness, worthlessness, suicidal ideation, and then you can also get these psychotic symptoms with depression. So like delusions of guilt, or they can have auditory hallucinations, or what's called Cotard delusions, which is when kind of they believe that they're already dead. So they'll say stuff like, there's no point doing anything because I'm already dead, or like they just really believe that they're not there, or that their internal organs are like rotting. And then there's the ICD-10 classification. So for mild depression, you have to have at least 2 of the core symptoms and then at least 4 symptoms in total. For moderate, you have 2 of the core symptoms and at least 5 symptoms in total. And then for severe, you've got all the core symptoms and at least a total of 7. You don't have to have psychotic features. I don't think for first year, I don't think you really need to memorize like mild, moderate and severe, but it's quite easy just to remember that if it's severe, you've got all 3 of the core symptoms. So next, SPA. How long must symptoms have been present for you to diagnose depression? I'll give it maybe 10 more seconds. Perfect. So you said 2 weeks, which is the right answer. So you need to have symptoms present for at least 2 weeks, and each symptom should be present at sufficient severity for most of every day. And there are loads of conditions that are linked with depression, and it's a bit of a like catch-22 whether the condition came first or the depression came first, or I think for some of them people don't really know like exactly how they're linked. But it's a lot of chronic conditions, so chronic pain, cancer, arthritis, diabetes, sleep apnea, hearing loss, MIs, stroke, dementia, Parkinson's. Hypothyroidism is one that's quite easy to remember because that's part of your kind of questions when you're doing the thyroid exam. But it's just really important to remember to rule out the organic causes of depression. So make sure that you do check their blood, so do a full blood count, ESR, use Nihss, LFTs, check their glucose, calcium, TFTs, just do a full screen of everything else that could be causing them to feel depressed. And it's really important as well when kind of taking histories from people with depression or low mood, just to do a suicide risk assessment. So even if they don't seem, particularly severely depressed, it's really important just to always ask, because if you don't ask, you won't know. And if they're not, if they're not suicidal, then they'll, quickly tell you they're not, but you just always need to check. And in terms of the structure, this is more like the structure for someone who's come in with a suicide attempt. But, ask kind of what happened before, during and after the event. Ask them about the future, do a depression screen, psychosis screen, take a medical history, medication history, family history and a social history. I think this is something that's more relevant in later years at medical school. I think this would be a bit beyond what they'd expect you to do in first year, but just for the future, it's good to know. But you should know about the risk factors for suicide. And if you remember the mnemonic SAD persons, it helps you to remember them. So S is for sex. So men are more likely to complete suicide. Women are actually more likely to attempt suicide. Age, so elderly people are more likely to attempt suicide, or adolescents. There's kind of a peak either side. And then if they're depressed, if they've had a previous suicide attempt, if they abuse alcohol, rational thinking loss, so if they're hallucinating or delirious. Ask about social support, if they have an organised plan, if they don't have a partner, they're more like, if they're separated, they're more likely to attempt to commit suicide, and ask about health conditions as well. So next question, A 20-year-old comes to see you at the GP surgery. He tells you that he's felt very low in mood for the past month. He was a keen cyclist but has stopped, as he says he doesn't have the energy anymore. He also tells you that he's been waking up in the early hours of the morning and struggling to get back to sleep. He says he cannot concentrate at work and has been eating much less. When you ask about the future, he tells you he has nothing to look forward to. He denies any suicidal thoughts. Which medication would you like to start? Give it 10 more seconds, maybe 5 more seconds. Perfect. Yeah, so everyone said C, which is citalopram. So that is the only one of those which is a selective serotonin reuptake inhibitor. And they are the first line for depression. Citalopram and fluoxetine are like the preferred SSRIs. The others are used a bit kind of later down the line. So in terms of antidepressants, there are 4 side effects of SSRIs that hopefully all begin with S. So they can make people feel sick. They can cause sexual dysfunction, in particular anorgasmia. They can initially make people actually more suicidal. So we always need to keep a close eye on people when you kind of start SSRIs. And sleep, a really big problem with SSRIs is they can cause insomnia. It's also just, I don't think you need to know loads and loads about the side effects, but it's important to know that tricyclic antidepressants are more dangerous in overdose. So you try to avoid prescribing TCAs to people who might be at risk of overdosing. So if anyone's suicidal, try to avoid TCAs. And you should never combine MAOIs and either SSRIs or TCAs because they can cause something called serotonin syndrome, which can be really dangerous. So one of your patients is unable to tell you her date of birth, her age, and to name the capital city of England. Which type of memory has been affected and which part of the brain might be damaged? We've moved on now to a bit of, I know it's been a bit of a jumbled up session, but yeah, this is just a bit of neuroanatomy for the last 2 questions of this section. So is that her retrograde memory in the medial temporal lobe, episodic memory in the medial temporal lobe, semantic in the medial temporal lobe, episodic in the lateral temporal lobe, or semantic in the lateral temporal lobe? It's a really tricky question, this one. But there's, yeah, for neuroanatomy, I feel like we used to get given really good sheets. I don't know if you guys still will get given them. But it's just worth knowing like a couple of neuroanatomy facts because they occasionally won't be a big part of your exam, but they do like to ask about them occasionally. Give maybe 5 more seconds. Cool. So move on. So the answer is actually E. So it's your semantic memory. So your semantic memory is your knowledge of facts and information. So it's things like your capital cities, your anatomical terms, just like names of things or figures. And that's affected by damage in the lateral temporal lobe. And your episodic memory is your kind of day-to-day record of personal events and episodes. And that's affected by damage in the medial temporal lobe. Just have to remember it, really. And next neuroanatomy question. So a gentleman starts behaving in an odd way. He engages in very risky activities and seems to be fearless. People suspect he's damaged the danger detector in his brain. which part of the brain do you suspect might be damaged? Is it the basal ganglia, subgenual area, hippocampus, amygdala, or the medial temporal lobe? So I'll give you 5 more seconds. Perfect. Yeah, so the answer is D, so it's the amygdala. So your amygdala is the almond-shaped nuclear mass in the anterior part of the medial temporal lobe. So it sits just in front of the hippocampus, and it kind of controls your emotional responses and your emotional learning. So it's called your danger detector, and it's what's kind of triggered if there's kind of threatening stimuli around. Cool, so that is everything for depression / mixed bag of things topic. And now we're going to move on to go through dementia. So as with the last one as well, this is a bit of a jumble, I'm afraid, but I'm going to start going through some anxiety disorders. So anxiety in itself is a normal response to a feared situation, and it becomes an anxiety disorder when it's out of proportion or when it persists once that like feared situation or stressor is gone, or if it just occurs when there's no stressor present at all. And there are a couple of different classifications for anxiety disorders. So the first one are your anxiety or your phobic disorders. So that category includes things like panic attacks, panic disorder, where you have these kind of recurrent unexpected panic attacks with no background anxiety. Phobias, which can be of specific things, or it can be kind of a social phobia, or your generalized anxiety disorder, where you've got this prolonged excessive anxiety that's not focused on one specific thing. So that's your first category. And then your second category are your stress-related disorders. So you can have an acute stress reaction, which is just an intense, unpleasant, dysfunctional reaction shortly after a traumatic event that lasts less than a month. You can have an adjustment reaction when you're just kind of going through a big life change and it's just a bit stressful. And you can have PTSD, which is where weeks or months after a traumatic episode's occurred, you're still having these flashbacks, nightmares, and increased arousal. And then the third one is OCD, where you get these obsessions, which are unwanted, disturbing, intrusive thoughts. And you get the compulsions, which are these repetitive behaviours or mental acts. And they must be kind of recognised as either useless or excessive. So one of the classic ones is being, slightly germophobic and being obsessed with germs, and then washing your hands, which in moderation would be useful, but they wash their hands so much that it's not useful anymore. It's excessive. So next question. A gentleman presents to your clinic 3 weeks after being physically assaulted on his way to work. He describes vivid nightmares about the assault that frequently wake him up at night. These have been occurring for the past 2 weeks. He's nervous to leave his house and has taken a day off work due to this. What's the most likely diagnosis? So is that an acute stress reaction, depression, agoraphobia, PTSD, or generalized anxiety disorder? Give it 5 more, 10 more seconds. All right, so we've got a bit of a split between C and D. The answer is actually A. So he actually hasn't been having these symptoms for very long, which is why it's more of an acute stress reaction. So for it to be PTSD, it needs to have been going on for at least 4 weeks. Whereas this is kind of, he has had a really traumatic episode and it's just been 2 weeks of him, you know, feeling acutely stressed. Agoraphobia is more like a fear of kind of going outdoors, whereas this kind of scenario is more focused on this one traumatic event, which is why it's the acute stress reaction. So we're going to move on now to kind of dementia and delirium. So it's quite a classic thing. I'm sure you've seen it before, these tables comparing delirium and dementia. Quite often you get a combination of both, where someone's got dementia and then they become delirious. But kind of the differences are that delirium is kind of quite an acute onset, so it's usually triggered by something. It's got this fluctuating course where sometimes you'll speak to them and they'll seem quite coherent, seem to understand everything, and then they'll kind of deteriorate and then improve again, and it's quite fluctuant, whereas dementia is a progressive decline. And then first you need to know, so in delirium their awareness is really reduced, whereas in dementia that's kind of remains the same, so they'll still kind of be aware of their surroundings, whereas in delirium they can be very unaware of where they are or things like that. Yeah, they're the main things to know. And then pinch me is this mnemonic that's used to help identify the causes of delirium. So delirium can be caused by pain, can be caused by infection. Infection is really common in hospitals for people to become delirious with infections. Nutrition, constipation, hydration, medications, and the environment as well. So for a lot of people, changing environments can trigger a delirium. And going on to dementia a bit more. So dementia is a decline in memory which affects everyday activities for at least 6 months. It's also a decline in other cognitive abilities, 6 months. They remain having this awareness of the environment, so that's what kind of differentiates it as well from delirium. And they can kind of have a decline in their emotional control or a change in social behaviour as well. And there are 4 main types that you need to be aware of. So the most common is Alzheimer's. That's 62% of people with dementia have Alzheimer's. Then vascular is the second most common. Lewy body is the third, and then frontotemporal is the least common. So next question. Mrs. Clark is a 76-year-old lady who presents to your clinic with her husband. Her husband tells you that Mrs. Clark has become very forgetful over the past month. She often can't remember conversations they had earlier in the day and has left the door unlocked several times. He is concerned that she's not eating as much as she used to. What's the most likely diagnosis? Give it 5 more seconds. All right. So answer, it's actually depression. This is a bit of a trick question because I know I led you down the path of dementia, but the reason this is more likely depression is firstly just to highlight the fact that depression is really common in the elderly and it's really commonly missed and kind of thought to just be due to cognitive decline due to aging, dementia, but it's really common, so it's really important to remember about depression. And in this case particularly, it's only been over the past month, so it hasn't been a long enough history. Like in the slide before, I was saying it needs to be a really progressive decline to be dementia, usually over 6 months, whereas this has just been over a month. and her symptoms are quite vague, really. So not eating as much and leaving the door open and things. They actually fit. They could fit with either. This question is a bit vague, but the most likely in this case is actually depression, just because of the time frame. So Alzheimer's disease is the most common type of dementia, and you can remember it by thinking about the 7 A's. So I'm not going to try and pronounce the first one because I will get it wrong, but we no longer realize something's wrong. Agnosia, which is you kind of stop realizing things through your senses as much. Aphasia, so you lose the ability to use language. Apraxia, so you struggle to carry out purposeful movement. Altered perception, amnesia, and apathy. And if you look at the brain as a whole, so on CT heads and MRIs of people with Alzheimer's, there are 3 main things that happen. So you get this cerebral atrophy, you get shrinkage of the hippocampus, and you also get enlargement of the ventricles as well. And in terms of the pathology, it's due to these beta amyloid plaques and neurofibrillary tangles. I wouldn't worry kind of too much about them, but yeah, the picture on the right kind of shows where they are in the brain. So the beta amyloid plaques are outside of the cells and they kind of disrupt the signals that way, whereas the neurofibrillary tangles are kind of actually in the cells and they kind of internally stop the signals being passed as well. But I wouldn't worry too much about that. Which of these is not a genetic risk factor for Alzheimer's dementia? I've been a bit mean with my questions today, so I'm sorry it's late and I'm giving you mean questions, but don't worry if you don't know the answers. Cool, I'll give 5 more seconds. Cool, so congratulations to those who said D. So going through them, APP is a precursor protein. When it's cleaved, it produces beta amyloid, so that increases your risk. Gene that codes APP is located on chromosome 21, so that's why if you've got trisomy 21, then you're more likely to have that precursor protein gene. The other one, presenilin 1, is linked to about 50% of familial Alzheimer's dementia cases. ApoE is a protein that handles fats in the body, including cholesterol. ApoE2 is protective, whereas ApoE4 increases your risk. And other risks are for Alzheimer's. So age is your strongest one, family history, if you've got a low socioeconomic or educational status, diabetes, obesity and dyslipidemia, hypertension, people of African American or Hispanic descent, lack of physical activity and traumatic brain injuries. And in terms of the medication for Alzheimer's, so there's no curative treatment, but there are medications that can slow the rate of decline. So there are acetylcholinesterase inhibitors. So like donepezil is probably the one you'll see probably the most, rivastigmine and galantamine. And then in moderate to severe Alzheimer's dementia, you can use an NMDA receptor antagonist, like memantine is the most common one. So next question, a 62-year-old presents to the memory clinic with her husband. Her husband first noticed her struggling to make decisions 2 years ago. He feels this had remained relatively stable until 6 months ago when she became more confused and started to regularly forget to buy items on the weekly shop. She has a history of high blood pressure and hypercholesterolemia. Which type of dementia is most likely in this patient? All right, 5 more seconds. I can see someone changing their minds a lot. All right, so answer is B. So that is because she's got this stepwise deterioration in symptoms. Sorry, I'll go back to the question. So she's got kind of a long-standing history of kind of cognitive decline. So that means that it can be counted as a dementia. But he felt it was quite stable, and then it's kind of suddenly getting worse, and then she's also got these kind of cardiac risk factors as well. So she's got the high blood pressure and the hypercholesterolemia as well. So yeah, clinical features, you get this stepwise deterioration. Symptoms will vary depending on where these lesions are. And you get personality changes a bit more commonly than in Alzheimer's, and your episodic memory is often a bit less severe than in Alzheimer's. And the important risk factors to look out for are the cardiovascular ones, so history of stroke or TIA, AF, hypertension, diabetes, hyperlipidemia, smoking, obesity, coronary heart disease, history of stroke or cardiovascular disease as well. If the question really heavily hints at cardiovascular risk factors, then they're probably trying to get you to think about vascular dementia. And in terms of the management, there's no pharmacological treatment that's known to help. And the aim of your treatment really is to just reduce the cardiovascular risk factors. So if they smoke, try and get them to stop, get them to eat a healthy diet, exercise, put them on some antihypertensive or statins, get their diabetes under control. So question 10, we're getting near the end now, I promise. Mrs. Norbert is a 78-year-old lady who presents to the GP with her daughter. Her daughter is concerned as recently Mrs. Norbert has mentioned that she's seen small people doing the gardening many times. Mrs. Norbert is confused and is unable to tell you her date of birth or what year it is. Her daughter tells you she first noticed her mother becoming confused last year. Mrs. Norbert has had multiple falls in the past, and on examination you notice a unilateral pill-rolling tremor. Her daughter comments that the tremor has been present for many years. Which diagnosis is most likely? So is it Alzheimer's dementia, vascular dementia, Lewy body? Ooh, let me just shut the last pool. Open this one. Lewy body, frontotemporal, or Parkinson's. I'll give you like 5 more seconds. Fine. So our answer is Parkinson's dementia. So in the question, kind of Lewy body dementia and Parkinson's disease dementia present really similarly, and it's important to establish which symptoms came first, and that's how you tell which which one it is out of the two. So in this case, the tremor has been present for many years, whereas the kind of confusion and hallucinations, which is what I was going for with the small people, a lot of the time in Lewy body dementia or Parkinson's dementia, they have kind of visual hallucinations, a lot of the time of animals or of kind of people. I don't know why in my head I have it to be gnomes. I don't know where that's come from. Maybe it's true, I don't know. But they often have these visual hallucinations anyway. But in this case, the Parkinson's type symptoms came before the dementia type symptoms, which is why it's more likely to be Parkinson's dementia. So Lewy body dementia, they have this fluctuating cognitive performance. Visual hallucinations are common, can have Parkinsonism, and commonly have kind of falls as well due to that. And I put a picture of Robin Williams because this is the type of dementia that he had. And in terms of the pathology, you get these Lewy bodies, which are alpha-synuclein cytoplasmic inclusions. It's basically a protein in the brain. In Lewy body dementia, it's a bit misshapen, so it clumps together, and you get these clumps of this protein over the brain. I think that's all you really need to know. That's probably even more than you need to know, to be honest. And last question. So a 46-year-old man presents to the GP with his wife. His wife states he's been very irritable over the past 6 months. He's had a few arguments with colleagues at work as well, which is very unlike him. His wife also says he's started eating much more, particularly sugary sweets. Which form of dementia is most likely to present with personality changes? So Alzheimer's, vascular dementia, Lewy body, frontotemporal, or Parkinson's disease dementia. Okay, 5 more seconds. So we had a bit of a split, but the answer is frontotemporal. So frontotemporal, things to look out for in a question stem are that it's a young person. Personality changes, I guess that's the point of this question, but personality changes are the most common in frontotemporal, and they can become quite aggressive. It's a really hard type of dementia to manage because it's young people with personality changes, and they can become a bit kind of disinhibited and eat loads of sugary sweets is the classic thing. They can also have this like perseveration where they repeat the same activity or say the same word over and over when it doesn't make sense. Generally, their memory remains a bit more intact than with the other dementias. And in terms of the pathology, so in the big picture, macroscopically, you've got atrophy of the frontal and temporal lobes. And if you were to look a bit closer, you get PIC bodies, which is why it's sometimes called Pick's disease as well. Gliosis, neurofibrillary tangles, and senile plaques. I wouldn't worry too much about that. The main one is kind of PIC bodies. It's called Pick's disease sometimes. So I think we've got to the end. Thank you so much for staying so late, everybody. I'm sorry it's run over, but I hope it's been helpful. If you could scan the QR code and give us a bit of feedback, that would be really helpful, and you'll get access to the slides if you do that as well.